If she regresses as of now, did one point no, 6 months after Pfizer applied, waiting all the time, and all they said is they were the longer they wait to try, they've been waiting a long time. Yeah, I think mid-20s. They basically said they will try, but the other so that's, let's say 9 months from now. No, that's what I checked with Dr. Charlie. That's very good. If she had a she was not good. That it's a soft sometimes it'll make sense about it. Very rare study. That's why it's not first line. That's why it's not being first line. I know there's one combination of it's on that. Yeah, Carlos, I think. Carlos is really strong in it.
So it's decided on that?
And it's supposed to be a little soft. And sometimes they say it sensitizes you. But it's all of a sudden you're sensitive to the eyes. Right now I think that we also practice a lot of communication. They don't plan to get it. So let's say one of them targets these 10 mutations, 9 of them. So you do a re-biopsy, how that's one. The other one doesn't. But other than that, they take it. Yeah, that was Yeah, no, I never lived there, but I was only hospital language. Private language is there. I didn't have it. I was not living there. So.
But no, we didn't go there. I remember we met.
I got met back down. I got married at 40. Oh, you got a little my wife was diagnosed at 42. Not a typical non-smoker Mediterranean diet on it. And she started to eat something with no red. I barely. You can't.
Really?
Sorry. When I joined moving to DC, I wasn't sure what the hospital service. I know you have, Georgetown has a national cancer and then Johns Hopkins. I'm here I wish it was real. Yeah, our first time was first trial was there. I don't like that. Especially you were more than email. I joked to my doctor here that that's where violent. That's he would probably just because we're not right now. I think it's very good for your assignment.
Sit down.
Which no, because apparently it's not good for you. I've read, I have no friends call the directors heavily into that one too. And you'll notice it's not as tough. I think you just get yourself. It's time.
Today, I see a lot of familiar faces in the audience to the Targeted Therapies and Lung Cancer Patient Forum. My name is Dr. Nate Pennell. I am a medical oncologist and director of the lung cancer oncology program here at the Cleveland Clinic Towson Cancer Institute. Welcome to our new building. We have been open for about 6 months. We're very proud of the building. Please feel free to wander around a little bit, look around, and then you'll get to see more downstairs at lunch. And we also have a beautiful Cleveland day. If you're not from Cleveland, it's like this all year long. Not a cloud in the sky. It's really nice. Just like Detroit. Exactly. So this forum is a really special thing. This is what, the fifth or sixth? Fourth? Yeah, something like that. And it's really a nice forum for patients and caregivers to be able to interact with doctors who are treating the types of cancers that they're going through. So in addition to being sponsored by the Cleveland Clinic, really the driver of this is GRACE, which is the Global Resource for Advancing Cancer Education. This is a nonprofit organization founded by Jack West in 2007, and so I became involved with GRACE in 2008. Actually, my very first ASCO as a faculty member, I went to dinner and sat next to this guy who kept talking about this website he was working on, and it was a little bit better than that. But he was looking for doctors to be able to participate, and it's something I'd never actually experienced before, where actually the doctors interact directly with the patients, with answering questions, providing content. And it's a lot like what we're doing today. The forum today is GRACE, but in person instead of what you get online. So what we are going to do today is you're going to see disease experts in the different targeted subtypes of lung cancer, EGFR, ALK, ROS1, BRAF, RET, ROS, the people who are actually doing the trials and publishing the papers on the drugs that many of you may even be taking now or your loved ones are taking, will be here presenting. This is not a science symposium for doctors and medical people. This is for you guys. This is for the patients and caregivers to try to understand what you're going through, what your options may be, and actually interact and ask questions. So a big part of this is asking questions. The general session is going to start now and go until 10 a.m. with a 30-minute break. Hopefully you guys all have your agendas. After lunch, there will be breakout sessions for the different specific types of genetic types of lung cancer. There will then be another break and then an afternoon session that goes until 4 o'clock. I hope everyone sticks around. It's very important during the breaks, during the lunch, actually go and find the faculty that you want to talk to. That's why we're here. We're going to be specifically available to talk to you. This is also being broadcast on the web, so welcome to everyone who's watching out on the web. I think over there. So the breaks and lunch will not be broadcast, but everything else is going to be broadcast. So we want lots of questions from everyone today, but it's a little bit different. So instead of raising your hand, please write your questions on cards on the credenza. I've been told that's what it's called. Over by the bagels, there's index cards, so you can write questions and turn them in. And after the sessions, we will answer those questions. You can also submit questions through email, and here are the email addresses for the different sessions, and we will answer those later on. Before we move on to the first talk, I also want to thank our generous sponsors for sponsoring this wonderful meeting. AstraZeneca, Boehringer Ingelheim, Ignita, Takeda Oncology, Genentech, Guardant Health, Caris Life Sciences, Smart Patients, and Novartis all contributed to make this possible. So thank you very much. All right, so to move right along. So the first talk of the day, I'm not sure who came up with the title, but I really liked it. It was called the Many Faces of Progression. And a lot of this is going to be kind of trying to set up what we're going to be addressing throughout the rest of the day. So what does this really mean? So when I was thinking about putting this talk together, when I think about the many faces of progression in lung cancer, the first thing that came to mind is that the face of lung cancer itself is changing. So much different from when I started practicing back in the mid-2000s. It's not just the 70 and 80-year-olds who've smoked their whole lives. Now we're actually worried not just, of course, about those patients, but also the 20-year-olds who are going to school and whose diagnosis is interrupting the beginning of their life, the young mothers with children at home who are dealing with this, and people who've never smoked who are getting this. And this is, I think we are successfully alerting the rest of the world that this is the face of lung cancer too. But unfortunately, when we talk about the changing face of lung cancer, as doctors, we also have to think differently about what we do when we're treating these patients. So the face of progression. And so when we talk about progression, because you'll hear that word a lot, progressive disease, what does that really mean? What it means is, you're treating patients with targeted therapies. We have some wonderful treatments we're going to talk about today that work very well for most patients with different genetic subtypes of lung cancer. But unfortunately, the reality is, for the vast majority of patients, these are not cures. Okay? They can put the cancer into somewhat of a remission, but sooner or later, the cancer will begin to grow. It's called acquired resistance. But that's what we mean by progression. The cancer is starting to get worse, and you have to make a decision about what to do about that. Now, traditionally, oncologists are used to dealing with that. You give chemotherapy, the cancer starts to get worse, you move on to something else. But the situation is not the same with targeted treatments. Progression in 2017 is not one size fits all, just like patients aren't one size fits all anymore. And the treatment of lung cancer used to be one size fits all. Everyone gets the same treatment, and now it's completely different. So you have to sit down and individually address progression with patients. And so I'm going to go through 4 different scenarios just to kind of illustrate some of what we'll be talking about today. First of all, generalized progression, or kind of what we consider typical progression, where all the cancer is getting worse. Situations where there is progression, but maybe it's actually not so significant that we have to make a change in what we're doing. Something called oligoprogression, which is progression, but not everywhere, just maybe in one spot or a few spots. And then finally, this unique situation where the cancer is progressing in the brain, but not anywhere else. So the first one, and this is what most oncologists are used to dealing with, is what we call generalized progression. We have patients who who patients who have lesions in the lungs, they have a nice response to a targeted treatment, but then after a certain period of time, all of the lesions begin to grow. It's clinically significant, perhaps patients having worsening symptoms, and you have to make a change. Okay, this is what we consider normal or typical progression. There's nothing fancy about this. Whatever you're doing is no longer controlling the cancer. You have to make a change. And a lot of how we then address the next step is what we'll be talking about today. Should we be doing a new biopsy? So we did an original biopsy to diagnose cancer and then to test to see if we could find a target to treat. Is there a benefit to getting a new biopsy, whether it be a liquid biopsy or tissue? And Dr. Reckamp is going to be talking about that later on this morning. Should we switch to a newer drug, something that's been designed specifically for this situation? A lot of the breakout sessions this afternoon will be addressing these, and of course we'll talk about that throughout the question and answer periods. And then finally, should we actually leave targeted therapy and move to something else, like chemotherapy or a clinical trial? Dr. Shah is going to talk to us about clinical trials in oncology, which, of course, is what led to all of the wonderful treatments that we have today and are very important. So this is a moment where I wanted to, it doesn't really fit in this, but I wanted to put a plug because there really wasn't another part in this morning to talk about this. When cancer's getting worse and there isn't a clinical trial or there isn't a targeted therapy that's a next generation inhibitor to take, and your doctor talks to you about chemotherapy, this is not the end of the world. Okay? Chemotherapy works very well sometimes for patients, especially for patients with genetically driven tumors like EGFR mutant cancers. Sometimes chemotherapy can work great. This is an example of a patient of mine who had progressive cancer in a lot of different places where all the arrows are pointing. And he had ALK-positive lung cancer, had been on both Xalkori and Zycadia that had worked for a while, but then stopped working. We moved to chemotherapy, and it worked great, had essentially a complete response. And actually, the duration of response of chemotherapy was longer than any of the previous treatments he had had. And so this is not the end of the world. It can work very well. And so don't despair if your doctor talks to you about that as an option. Okay, so the first kind of unique, special type of progression that I want to talk about is this. So this is a patient of mine who had a very nice response to a FATNet. So this is EGFR mutant lung cancer, had big liver metastases. Most of them resolved or got very small. And this is the residual, one residual lesion. And so we get the scans periodically every few months. And then about 12 months later, I looked at it myself. It hadn't been read yet. And I was like, it looks about the same. Things haven't changed too much. But then, of course, the CT report says, uh-oh, we measured this, and it's clearly progressing. Cancer has progressed, okay? Well, if you just looked at this and I didn't put arrows showing that there's a 2 millimeter difference in size, would you have guessed that there's a difference in the size between those two lesions? If you fool yourself and look at it, okay, maybe it's a little bit bigger, but honestly, when I talk to my fellows about how to read these scans, the first thing is you have to look at them yourself. Okay, you can't trust a report of a radiologist saying cancer is getting worse. You have to look at it and determine is it important or not. And two, if I can't just look at it and tell that there's a difference, there's probably not a real difference there. Okay. So this is actually a fairly common phenomenon for patients who are on targeted therapies like EGFR TKIs, ALK TKIs. In fact, there's even been very nice papers published specifically looking at T790M positive EGFR mutant lung cancer, which is the most common type of resistance for EGFR, that these tend to be more indolent. Even in a dish, they grow much slower than the original EGFR mutant lung cancers. And oftentimes, you can actually just, wait a minute, look at it. You don't have to make a change. Patients often feel fine. And if there's no significant change, you can actually continue on the treatment without jumping in. And this is particularly relevant today because we actually have treatments to move to. There are people out there arguing we should be monitoring blood levels of T790M because the first time you see it appear, you can immediately make a change to your next treatment. And I'm not sure that that's necessarily the right thing to do. This is another example of a woman with EGFR mutant lung cancer. So she presented with multiple areas of consolidation within the lungs, lymph node involvement. We biopsied it, had an EGFR mutation, started on Tarceva. She had almost complete resolution of most of her lesions, although still some residual areas in the lungs that we followed. This was her most recent scan in the last month or two when I looked at her. Now, compared to that, that's worse, right? That's pretty dramatically worse. What if I told you this was her scan 6 months ago? We actually moved to 6-month scans because she got tired of having to get scanned every 3 months for her scans. And if you put them all together, you can see, sure, there's a progression that's clearly worse. The first scans were in 2011, and the most recent ones are in 2017. She's doing great. She doesn't have any symptoms. We've never tried to change to anything else. I've talked to her about this. We could switch. She doesn't have T790M. We could switch to chemotherapy, but she doesn't want to do that. And she doesn't need to because she's doing fine despite slow indolent progression. So, well, I tried to talk to patients about this. When they come in, they're like, what about this new drug? What about immunotherapy? Should we switch? It is a race. You know, I like the race analogy because I'm a runner. But it's a marathon, okay? This is not a sprint. There is no rush to hurry up and use all of your newest, best treatments as soon as possible. We want to stretch things out. Patients with these types of cancers are now living for years, and we don't want to abandon things that are working too soon. That's my thought, anyway. Okay, so the next thing I want to talk a little about in terms of a special issue, and we're going to talk, Dr. Gadgeel is going to talk a little bit about this next, is what's called oligoprogression. Okay, so oligo means one or a few, and this is a specific patient that has, again, I think this is EGFR mutant lung cancer, had a lesion here that more or less disappeared on Tarceva. But then, you know, it's not very big, but over a few months developed a lesion that was growing back in the place where our previous one was. So what do we do at this point? This is the only area that's growing. Everything else is basically the same. So this is to borrow a quote from my friend Ross Kemage at University of Colorado. You don't need to necessarily overthink this. Yes, the cancer is getting worse. Traditionally, we stop our treatments and we move on to something else, but maybe you don't have to do that. Maybe you can actually weed the garden and actually just pluck that weed out and take care of it without having to change this. And we're going to hear a little bit more about this, but and the other thing I want to emphasize is you do need to be careful about what you mean when you're talking about oligo or, you know, how many lesions, because sometimes is 10 lesions getting worse oligo? I don't think it is. You know, I prefer one, but sometimes a few might fit into that as well. So this is the patient. And then now, 6 months later, after getting stereotactic radiation to that lesion, it's completely gone, still on Tarceva, haven't had to make a change, and doing very well. Oh, looks like I didn't get my extra stuff put in there. That's okay. So we're going to talk about the final situation that is kind of a special type of progression, and that's progression in the brain. So this is a patient of mine, EGFR mutant patient who was on Gilatrif, did very well, was leading a very active life, only 31 years old, when he had a seizure. And MRI showed multiple enhancing lesions within the brain. He was very opposed to radiation. He thought it was a very toxic thing, and he really was prepared to die rather than go through radiation. So, but when we did scans, nothing else was worse. All the other cancer in his body was still under control. So is this a situation where he developed resistance? Was the cancer resistant? Not necessarily. We know that most of the drugs that we use to target EGFR, ALK, ROS1 don't penetrate into the brain the same way they get into the rest of your body. The brain has something called the blood-brain barrier, which prevents poisons and toxins from getting into the brain. It also tends to prevent chemotherapies and targeted therapies from getting into the brain. So it may still be sensitive to treatment, but the drug just can't get there. Okay? So traditionally, what we do for these patients is we do radiation to the brain, because radiation can get into the CNS. So this is very similar to the sort of weeding the garden thing, but on a more broad base. But this patient didn't want radiation. So we're very fortunate that newer generations of drugs are now coming out that can be active within the brain. This is just an example of two monkeys. This is Iressa, which is a first-generation EGFR inhibitor that's labeled to something that lights up in a PET scanner. And you can see the brain is completely cold. None of the drug is in this monkey's brain. But Tagrisso, the new third-generation inhibitor, actually is lighting up within the brain, suggesting that it's a drug that can get in there and actually be active. And we'll talk a little bit later about some of the data supporting that. So this is our patient and his brain progression. He wasn't T790M positive on a blood test, and he had nothing else to biopsy. And this is him now 1 year later on Tagrisso with almost complete resolution of his brain lesions and still doing well without having to have radiation. So just to line this up, again, this is not a race to try to get all of your treatments done. There is time to sit down with your patients and consider what the best treatment is, what's the best approach. And sometimes taking a step back and waiting to see what's going to happen is not the wrong thing. So acquired resistance and progression is not the end. It's actually just the beginning of the next step. And the approach has to be individualized. And some of our treatments are really changing that are helping us address these patients. All right. Thank you very much. Are we going to do questions after each talk? We're going to do the talks and then the questions at the end? I can't remember. Questions at the end. Okay. So now I want to introduce Dr. Shirish Gadgeel. Gadgeel? Doesn't matter.
I started calling myself Gadgeel. That's what everybody calls.
Okay, so he's the head of the lung cancer program at the University of Michigan in Ann Arbor, Michigan, formerly at Pennell Cancer Center. And yeah, go big bird.
It's a little bit difficult for me. My son is at actually Michigan State, so I try to damp.
I'm a graduate.
Yeah.
And he's going to talk to us a little bit more about locally ablative therapies, similar to the weeding the garden that I talked about. Thanks.
So thank you very much. I would like to, first of all, thank Nate and Jack for coordinating this event. I actually like to come to this because I get to meet some of my patients and like to be with the faculty. I learn as much as all of you. So I really am glad that I was invited again. I must not have screwed up too much last time. I really have very few slides, and in some ways, I'm just going to highlight what Nate mentioned. Before I actually go on to the case I have, and really it emphasizes the same points that Nate mentioned. And the reason I think we are focusing on progression is that there is, both in patients and in physicians, now a much higher level of expectation, particularly in patients who have these what we call driver genetic altered lung cancers. We expect those drugs to do very well for a long time. And whenever there is progression, be it within 6 months of starting treatment or 10 years after starting treatment, it's a huge sense of disappointment. And I think why we are focusing on progression is progression doesn't mean we don't have any options left. And there are a variety of ways of addressing progression. So a couple of things that Nate mentioned before I actually come to the case that I have. One is chemotherapy. I can tell you, and I hate to start off with chemotherapy because that's the last thing, especially patients who have these driver genetically altered lung cancers, is that why are you talking about chemotherapy? And many patients view that if we suggest chemotherapy at some point along the course, that's the end, that there is nothing further beyond that. And I would say that we view that in patients as another tool. We have a variety of tools to manage the cancer. And chemotherapy doesn't mean there's nothing further. And sometimes chemotherapy may be the best option, at least to control the disease for a period of time before other options open up. So I would like to emphasize what Nate said, that don't view chemotherapy as sort of the end of the road. Yes, you do want to not start off with chemotherapy or not use chemotherapy before other good options that we have, but just because chemotherapy has been suggested, that doesn't mean that we are at the end of the road. The second issue I would like to mention, Nate mentioned just because there's progression doesn't automatically mean there's a need to switch treatment. I would also extend that to these days, literally every month you're hearing some wonderful news in lung cancer. And I can tell you, sometimes it's most challenging to convince a patient who is doing well on their frontline drug, be it EGFR, be it ALK, BRAF1. We are seeing good shrinkage in the tumor on the scans. Patient is doing well, tolerating the drug very well. But we keep getting this news. There's this new immune therapy drug, or there is a new drug came along. I can tell you, as far as EGFR is concerned, there's a patient of mine who has been on now afatinib for almost 9 months. And of course, the osimertinib frontline data came out, and he wanted to switch the very next day when he read the news report, and I said, no, your cancer is doing very well. He hardly has any evidence of disease. He's doing well on afatinib, and that does not mean that we respond to not only every scan, as Nate said, in terms of progression, but every news item, every new discovery made regarding lung cancer. That doesn't mean we have to switch on to treatment. If something is working, we don't use that or let that thing work as long as it's going to work, and then you go to the next thing. So this is, again, as I mentioned, the case that I'm going to present is to emphasize how, in light of progression, even with all the wonderful drugs we have, we don't have to switch because it can provide that long benefit. It can provide another 10 miles in the marathon, and so that you can finish the marathon very well. So this is a 55-year-old female patient. First I saw in February of 2013. She had some upper respiratory symptoms. I don't believe it had anything to do with the lung cancer, but happened to get a chest X-ray because of that. And I wish I had all those wonderful scans that Nate presented. And I'm sorry I put this together at the last minute. But she had a left-sided lung cancer with lymph node metastases. That is, it had spread to the lymph nodes in the middle of the chest, and that's considered stage 3. Interestingly, she had a suspicious lesion in the liver. We initially thought when we looked at the scans that she had stage 4 disease. That's why we sent the biopsy off for testing, and she had EGFR mutation exon 19. It turned out the liver was actually a hemangioma, and so she was treated with chemotherapy and radiation for the stage 3 lung cancer. She had a wonderful response. She tolerated the treatment very well. The tumor shrank very well. So we decided to consider surgery. She was taken to surgery. The surgeon opened her up. But unfortunately, at the time of the surgery, she had multiple lymph nodes that were multiple. There were 3 that were sampled, and unfortunately, all 3 were positive for adenocarcinoma. So the surgeon decided to come out, did not do a complete resection. So she had chemotherapy and radiation for stage 3 disease and still had active disease. And therefore, at that time, because of her exon 19 mutation, I put her on erlotinib or Tarceva. That was back in 2013. My plan was to give it for 2 years because that's what many of the trials had done, sort of in the adjuvant setting, though this was not the adjuvant setting, but I was treating her when I had no clear evidence of disease on the scans. So we gave it for 2 years. At that time, some data about adjuvant erlotinib came out, which suggested that after you stop after 2 years, the disease tends to recur relatively quickly. So I encouraged her to continue for 3 years. She did, but 3 years afterwards, she stopped. She said, I'm going to stop. So in October of 2016, on a routine scan, her left adrenal gland increased in size. So we did a PET scan, did a brain scan. She had no other site of disease. So she had the tumor resected, this adrenal gland resected. And this adrenal gland showed the exon 19 mutation, but also had the T790M mutation. We did send her blood, and actually this is wrong, her exon 19. We sent Garden just to see whether we are detecting T790M somewhere else, but in the blood. And in the blood, we actually did not detect exon 19 or the T790M. So she had no obvious evidence of disease on the scans. Her only area had been resected. And at that time, I had the option, osimertinib had been approved, so I could put her on the T790M inhibitor. But I said there's a possibility, since we have been following you fairly regularly for 3 years, that there's a possibility that this is the only area where this mutation has evolved. It is possible that there are other areas where this mutation, the T790M mutation, exists. But at least in those areas, it is not progressing very rapidly. Let's restart you on erlotinib, see how you do, and at any evidence of, slightest evidence of progression of disease, we can switch you. The drug is already available. So I saw her in August of last year. So she has been now since November of last year on, continued on erlotinib. And she clinically has done very well. And in August of this year, we repeated her scans, and still her scans don't show any evidence of disease progression. I can tell you, I'm sure there are many, many much smarter experts than me who would have felt going on to Tagrisso would be the right option. And I'm not suggesting what I decided with this patient was absolutely correct and would be the way I would do with the next patient. What I'm just suggesting is that even though in this patient we did identify T790M mutation, that didn't automatically mean that we had to switch treatment. Of course, we had scanned her and I had seen her, been following her for a long period of time. We didn't have any evidence of disease. I know this patient is going to have disease progression. I don't know when she's going to have disease progression, but I know that I have a drug that I can start her on. So what Nate and we have talked about is patients who have progression. But there are patients who have stage 4 disease, but their stage 4 disease is what we call oligometastatic. So we can have oligoprogression, that is, it has progressed only in certain sites. But we can also have patients who have what is called as oligometastatic disease. That is, to begin with, yes, it's stage 4, but only limited sites of disease. Right now, actually, just yesterday in clinic, I saw a patient who had a right upper lung mass and a right adrenal metastases, biopsy proven, we biopsied the adrenal. Nowhere else the patient has any disease. And so our plan is to give him 3-4 cycles of chemotherapy based on response. We are going to resect both these lesions. So there is, apart from oligoprogression, there are patients who have what is called as oligometastatic disease. And we do have some data regarding consideration of what we call local treatment. So you can start off with systemic therapy for stage 4 disease. But if patients have limited areas of stage 4 disease, lung, and then maybe 1 or 2 other sites, one could start off with systemic treatment, be it chemotherapy, be it EGFR drug in EGFR patients, be it ALK drug in ALK patients. And after they've got a good enough response, after a few months, one could consider doing localized treatment to the areas where the cancer has spread to, be it surgery or be it radiation. There was a study that there are a lot of concerns about the study. Most importantly, it's a very, very small study of 74 patients run out of MD Anderson and 2 other sites, where in patients who had only 1 or 3 other sites of metastases, these patients, after they got initial systemic therapy, and this included chemotherapy in patients who did not have the genetically altered lung cancer, after they got a response or benefit, usually about 3 months, they were randomized to surgery or radiation, depending upon what made most sense in that particular patient, or just continuing the EGFR drug, the chemotherapy, or the ALK drug. And then after the surgery or radiation, the patients who got surgery or radiation to the limited areas of metastases, then they were restarted on whatever treatment they had started off with. And this suggested that the tumor control was longer. We can go into issues about this study. And it appeared to be that the tumor control actually was maybe better in the EGFR patients, so the numbers are very, very tiny. And I'm not saying that we have started doing this now routinely just because of this study, and there are other studies that are looking at this aspect. But this is something that we do consider in patients who have stage 4 disease, but limited areas of metastases who have a good response. That sort of focused treatment to the known areas of disease may provide an opportunity to control the disease for a longer period of time. So really, that is what I wanted to talk to you about. Progression is something that occurs and occurs at different time points. And it is not something that should lead us to think that, oh my God, we don't have options. We have actually a lot more options. And those options don't always mean going to the next and the best drug, but may mean doing some other things, including possibly chemotherapy, which may allow us to control the cancer for as long a period of time as we can. Thank you.
All right. So thank you very much. much. The next speaker is Dr. Karen Reckamp, who is Associate Professor of the City of Hope Comprehensive Cancer Center in Los Angeles. So she had a long flight to get in to see us today. Thanks so much for joining us. She is also the Director of Clinical Trials and the Medical Director of Thoracic Oncology, and is going to talk to us about biopsies and re-biopsies in terms of treating patients.
Thank you. I'm happy to be here today. And Nate tells me that the weather you have right now is how it is all the time. And I said, just like us in Los Angeles. But I'm not fooled because I'm from Chicago and I know better. But it's a beautiful day today. So I'm going to talk about biopsies and re-biopsies. And really over the past decade, a little bit more, I have to thank our patients, because the reason we are as far as we are in understanding the biology of lung cancer is because our patients have agreed to undergo biopsies and many, many, many re-biopsies. So there are lots of ways to do a biopsy. And in the past, it's been through, most of them are generally CT needle-guided biopsies or ultrasound-guided biopsies, bronchoscopy with either fine needle aspiration or biopsies, a little more invasive. More invasive than that is a surgical biopsy, usually through VATS. And now we're moving toward more liquid biopsies. And as anybody looks at these pictures, probably liquid biopsies would be the most acceptable to patients, especially when we're asking for many over time. So this is just a table kind of breaking down the biopsies and kind of looking at some of the pros and cons, because they all have a little bit of difference. In the past, a decade ago, a little bit more than that, before we knew about these mutations, we really wanted the smallest biopsy possible to get a diagnosis of either non-small cell lung cancer or small cell lung cancer. And it was really ingrained in our radiologists, in our pulmonologists, to get a very small sample because you didn't want complications. As you see, these biopsies are invasive. And so really fine needle aspirate is what we got most of the time. You got a few cells, and you had to tell were they small cells or big cells. And then that was about it. And then you gave chemotherapy, one type or another. And it's generally more low risk. But you get small amounts of tissue, which is generally not as acceptable in today's day and age, where you really want molecular testing and now PD-L1 testing on patients with newly diagnosed lung cancer. And so we are getting better and can do some of these tests on cytology. So if the cytology is the only safe way of doing getting a sample, that is still acceptable, and still testing can be tried and should be done. Core needle biopsies, there's more tissue available, higher risk of complications, not always safe. Surgical biopsies, again, generally by mediastinoscopy or VATS, much more tissue available. You can see some of the architecture to understand the tumor. You can see a little bit more of the heterogeneity potentially when there's a resection, but it's got the highest risk of complications, and again, not always safe and feasible. And then we move toward liquid biopsy, which we'll talk about a lot during the course of the day. Generally blood and urine samples, safe, convenient. You can look at tumor heterogeneity, which we'll talk about, and you can access tumor tissue over time and see how it changes, which has helped us dramatically in understanding the biology of lung cancer and helping to develop new therapies. It's limited in sensitivity. A negative result, what I tell my patients, is uninformative. Negative just means there may not be enough cancer cells. They can find the gene mutation. It's uninformative. So you need more information either at a later time or through a biopsy or something else. There are limited validated uses. There is a blood test that is approved by the FDA, but most of the tests have not been validated. And they can't be used for diagnosis or for some types of resistance, and we'll talk about that. So the reason biopsies and re-biopsies are important, all the things we're talking about today, and this list gets longer and longer. The number of drugs gets longer and longer as years go by. And so there are lots of reasons, targeted therapies, and then potentially moving toward immunotherapy and PD-L1 testing and mutation testing within the tumor to help guide therapy. And does it matter? The answer is yes. And you've heard stories from both Nate and Shirish today about patients who live longer because they're getting targeted therapy. And clearly this is showing patients who get targeted therapy who have a target found on genomic testing do live longer than those who don't get those targeted therapies or don't have that genomic change. So the other piece is PD-L1 testing. Is still the best test we have right now for immunotherapy. And this is more about genetic changes and not about immunotherapy today. And immunotherapy generally has a little less limited benefit in patients with these genomic alterations. But PD-L1 testing does help us understand who might benefit from immunotherapy over chemotherapy in the frontline setting if there are high levels of PD-L1 over 50%. And so patients need biopsies and tissue to understand the immune environment also. So barriers to tumor tissue biopsies is that they're more invasive with the potential for morbidity, mortality, complications. The feasibility of repeat biopsies is low generally, but like I said, our patients have undergone many, many biopsies for our understanding of this disease. The quantity may not be sufficient for testing, and generally it's been thought that tissue is the gold standard, but I would say a positive result is the gold standard because we've seen tissue results be negative, positive in the blood. So what our gold standard is shifting. And we may not always need tissue. So talking about liquid biopsies, there's an approval for blood tests to look at EGFR and T790M mutation. And this is just to show you, not that you're supposed to learn from this slide, but this is to show you that it's complicated. So many lung cancers, this is a study looking at blood from a single time point in lung cancer and showing the very significant heterogeneity that is seen in lung cancer. And so that heterogeneity, when you can imagine, when you look at a biopsy that's a small piece of a large tumor, you're looking at a very small part of it. When you can look at the blood, you can look at a more dynamic, a larger part of that sample. So it really does help you see the full cancer in a better way. So liquid biopsies potentially can be used across the spectrum. We haven't gotten to the point where we're using it for diagnosis, but potentially looking at circulating tumor cells. Looking at molecular diagnostics is the biggest area where we use it right now. At this point, we're looking at specific time points. Is the EGFR mutation there? Is the T790M mutation there? And then as others have discussed, potentially over time, we just don't know what that means and when we should change therapy. And as you can understand, changing therapy without symptoms may not be the best thing to do for patients. But we are in the era of liquid biopsies for sure. And there are many things that we can test from the blood. At this point, again, we're using mostly for genomic alterations, but this is moving forward, and again, looking at the tumor microenvironment and understanding our immunotherapeutic options also maybe in the future. So the other problem is that there are many ways to look at the genomics of a tumor, a tissue, or the blood. So you can look at single genes, and generally you can find you need a small amount of blood or tissue to look at single genes. You get a small answer, and you do get some false negatives in these from these tests. You can do more targeted and hotspot sequencing, which gives you a little broader answer, or you can do genome-wide, which gives you the largest answer. The question is, what do you do with all that information? And so we haven't gone far enough that we know what to do with each gene, and which there are many genes that come up in these analyses that we don't know the meaning of. And most of that is research-based. We're starting to understand the meaning of that, what causes resistance, what are important genomic alterations that may have targets, what drugs may be targeting those. But there's a lot of information out there that we don't know how to use yet. And this is a little bit on cost. This is from 2016. presented at the ASCO meeting. But what you're looking at here is blood testing. So next generation sequencing with the broadest panels has the highest cost. More specific, small gene panels have lower cost, smaller answers. Turnaround time is generally shorter with the small gene panels. The other piece about circulating DNA is that when you have a small amount of tumor burden, you're less likely to see a positive result. You're less likely to detect that tumor in the blood. So as we were talking about oligometastatic disease in one place, only in the lung, very commonly we see negative results, and testing the blood over and over may not be the most beneficial way of looking for things like T790M mutation or other mechanisms of resistance. But when we do find things like T790M, and this is where we have the most information, the blood and the tissue seem to produce the same results. So these are waterfall plots looking at responses, and so the longer lines are tumors that are shrinking, the shorter line tumors that are not shrinking as much. Most of these tumors are at least shrinking a little bit. And what you see here on the top panel is the tissue, on the bottom panel is the plasma, and you see similar results for both. And so that's important too. So not only can you get similar results in the blood, but the responses to the therapies we have are very similar, which has really helped us to say a positive result in the blood is something that is positive and can be treated. And again, this is showing the progression-free survival also in the blood and in the tissue. And mostly this is just showing you that they are similar and can be used and have similar patient outcomes. Urine is another platform that can be used to look at this point, hotspot mutations, and also can be another place to find mutations when one or another is negative. So what you see here in these circles, the outliers in this study, there was a portion of patients who only had T790M in the tissue, a portion only in the urine, a portion only in the plasma. So about 50%, a little bit more, were positive in all three. So again, a positive result generally means a treatable result. A negative result, uninformative. And sometimes doing multiple tests can help you get to the positive result. And this is just showing that over time you can see dynamic changes. So this is again looking at T790M. And as patients are retreated with a T790M inhibitor, the levels go down. And what about PD-L1 assessments? And this is, again, from tissue, we know that there is heterogeneity within the sample, within samples over time, and there are multiple ways to test T790M, and there's not always, between readers and between samples, there's not always concordance in the samples. So PD-L1 is also an imperfect test, but it's still something that we use right now to understand if patients can receive immunotherapy alone as their first treatment when they don't have a targetable mutation or gene alteration. And again, this is showing in multiple blocks of the same tissue, more heterogeneity, so it's spatial and over time. We can find PD-L1 from smaller samples, so from fine needle aspirations and the cytology samples, T790M can be, or T790M, PD-L1 can be assessed, and but it again may not be concordant with the tissue sample. Circulating tumor cells can also express PD-L1. At this point, this is still very experimental and in concordance with the tissue, and the results from the actual treatment have not been demonstrated. So those are areas we're going. Also looking at mutational burden in the blood is an area where people are looking to help understand whether immunotherapy may be more beneficial in patients. So then we move to resistance and why we have to re-biopsy. And this has, again, been discussed. This is, again, showing you there are many ways of developing resistance. And understanding that biology really helps us to get to the right treatment for people, because not everybody's next treatment is going to be the same. these are, again, showing multiple specific mechanisms of resistance. I would point to the last column of the other. Very importantly, a liquid biopsy will never show you that you have small cell transformation. And generally, that's an area that needs to be treated right away because it acts more aggressively. And so a EGFR lung cancer that is rapidly progressing, that has a negative blood test, should be biopsied and look for small cell transformation. Multiple mechanisms of resistance also to ALK. We're not quite at the space where we're treating based on resistance, but now with the multiple inhibitors that are out there, and I'm sure Alice will talk about this in detail, we will be treating based on resistance and molecular changes. So this is just showing patient developing resistance and looking at different treatments over time. And so when something gets broad here, that it's more highly seen in the blood, and when it gets narrow, it's to zero, it's not detected, so the ND is not detected. And here you see multiple, so again, over time, the tumor gets more heterogeneous. And so the blood may actually help us get a better picture of what is actually going on. So this is a patient who developed T790M, and so you see the EGFR mutation and the T790M to the left. Over time, lost those and was responding to therapy, and then developed multiple mechanisms of resistance, including the C797S mutation. And this is a patient that had, again, they developed progression on erlotinib, had T790M, had a response on osimertinib, had progression again, now had more complex genetic alterations, and this is what we see. And they went on a trial that we have open with osimertinib and necitumumab, and is now responding. So again, this helps us to understand what we might be able to do next. Usually after osimertinib, we're thinking about chemotherapy or other clinical trials at this point. So we are moving towards sequencing based on liquid biopsy. I would also caution, as you've heard before, that not all progression is the same, and if there are no symptoms, that continuing with a therapy until some symptoms develop, until there is significant progression, is usually best, because we have only limited amount of time on each therapy that we have. And so we want to get the most time out of each therapeutic option that we have. And so looking at tumor mutations over time in the blood, you have to take that with a grain of salt, because the clinical picture is always the most important. And again, what I tell my patients, when I look at them, the most important thing is what I see and what the symptoms that the person has in front of me. The scan is one piece of information. The tissue biopsy, the liquid biopsy is another piece of information, but the most important thing is that person in front of you. And if they're having symptoms, even though there's no growth on the scan, that's important. If they're not having symptoms, even though there is growth on the scan, that's important. So we treat the person in front of us. So again, tissue is still a problem and an issue, and we really are moving toward liquid biopsies, and I think that's kind of the standard of care as the first step as we move toward re-biopsies. The places where I don't do necessarily liquid biopsy is if the tumor is growing very, very quickly, then I think that we need to look for transformation or other things. But the cost is high, and the complications are more. Liquid biopsies are feasible for most. They're non-invasive, less risk. We can see the dynamic process of the tumor, and we can detect early resistance. There are multiple platforms, all of them with different sensitivities. So again, remembering that a negative result is uninformative. You need to move on and get other information. There's variation in the gene analyzed based on the platform used. Most of the studies are based on retrospective analysis, so we don't have the validation. And we don't know that when to change therapy based on those results. And there's a potential for false negatives. And then there's a cost too. They may be lower cost, but you're doing them many over time, so those costs add up. And so thinking about, I know people who get them very, very frequently, looking. At some point, you have to dampen that need that you need to look all the time and do it in a sensible way. And again, if there's not much tumor burden, continuing to look by blood is probably not the best way to do it. You need to move biopsy because you're going to get continuous negative results. And I have an example is I have a patient who's probably had EGFR lung cancer since about 2008 or so, has had multiple therapies, and before osimertinib was approved, we were trying to get her on trial. We're doing many, many biopsies of this area that's growing, and always negative. Couldn't get her on trial, doing other things. Finally, she developed a adrenal mass that we could biopsy, and it was T790M positive. And probably the whole time it was T790M positive, but now she's on osimertinib and responding very well. So just because it's negative doesn't mean it's always negative. So that's the other thing. So somebody who's T790M negative, maybe a blood test, maybe a biopsy, further down the line, I mean, you have to treat that and move on, but further down the line, testing again is going to be important. So this is just a schematic for treating non-small cell lung cancer, I would say today, because tomorrow it could change. And so we have ROS1, ALK. I did not put BRAF in here but I'm talking about it later today if you're interested. EGFR mutation, now we have the option potentially of first, second, or third generation inhibitors since last week, and the data presented at ESMO. And then looking at PD-L1, and then squamous cell, where we still have less options, but have the options of potentially treating with immunotherapy or chemotherapy. So again, I will leave it at that, and hope that and again, I want to express my appreciation for everything that people have gone through to help us understand this disease.
Some Q&A. Let's see. Do we have elected?
So I think as I don't know if Carla's in the room. Yeah. So we'll collect questions from people on the index card. I guess we've got.
Sure. I think we're going to need to. Do we need to be at the mic in order to hear on the webcast? So we can sit up here and answer questions.
These are all mics.
Perfect. All right. Yeah. Why don't you guys come on up?
Okay. Oh, sorry. You too. So just for the people who haven't spoken yet, I'm Jack West, medical oncologist in Seattle, focused in lung cancer, and also founded GRACE. And on the end is Dr. Alice Shaw, who is from Mass General and has a huge expertise in thoracic oncology and targeted therapies, especially ALK and ROS1. So I'm going to take some questions. I also have some from online too. I should start by saying there are a couple of things. One of the challenges with GRACE in general, an event like this, or just any time, even in the clinic, is jargon that we become completely insensitive to, because the curse of knowledge. We can't even remember not knowing what these terms were, but that's not the way it is for you. So just to back up a bit, because please, I would encourage everyone to just shoot up your hand and say, what's this mean, or what do you mean by that? You're definitely not the only one who doesn't know what that term means, okay? So it is never a bad question. The only bad question is the one you don't ask, okay? So please have a very low threshold to ask. It just reminds us what we need to back up and explain. I would mention cytology, which is not necessarily a word everyone knows. It means just an analysis of just the cells. So that's that. So that's usually for things like when it's a very small biopsy or filtering cells from fluid, things like that. In addition, VATS is video-assisted thoracic surgery. And when we talk about sensitivity and specificity, that sensitivity just means the ability to detect what's really there in truth. So sometimes when things are too small to be seen on scans or too rare to be picked up on a test, it's still there, but we just can't know it's there. So that is diminished sensitivity. Specificity is being able to believe that what you see is real. So, if I were to do a pregnancy test and it comes back positive, that is not a specific test, hopefully. I have no big surprise.
You also get a lot of standard oncology charts without really explaining what.
Right. So that's a great point. I think it's worth even thinking about, and I would encourage you to chime in now or during breaks about your own thoughts about presenting stats, because that's largely the language of how we decide what is the best treatment. I don't know if most patients, caregivers, and I don't know if it might be a very individual idea of whether you like having those stats of averages or seeing curves, or if that is too much information and not welcome. But the curves you probably see the most of are called Kaplan-Meier curves, and those are the ones where there's lines that are moving from right to left, and time is that horizontal change. And the downward slope is things not going as well. That is, it could be progression-free survival, where the lines going downward represent people whose cancer has progressed, and if it's survival, it's people who have died over time of treatment. And so when we see curves with two lines and there's one that is apart from the other, one on top is doing significantly better than the ones on the bottom. And so that's a common curve that we look at and think about as we are talking to ourselves and to you about this treatment is recommended over that one. The waterfall plot, Dr. Reckamp explained, and I'll just reiterate, is bars going up is the cancer growing, and bars going down are the cancer shrinking. Each bar is an individual patient, and the measurement of their dimensions of their cancer that we considered from a baseline of going on to a treatment. And the more bars going down, the better. And the further they go down, the more shrinkage there is. So that's the basic concept.
All right, so we've got a selection of questions.
And we don't need to cover every one of these now.
No, of course. Yeah, a lot of these are going to be questions that are going to be specific sessions, but just looking at some of the ones that we addressed today. So we have a question on liquid biopsies. So, and this is, I guess I would say, what is the role, or is there a role for sending serial biopsies over time today? Does it matter whether they're all done in the same lab? And then is there any issue with costs and paying for these things?
So again, doing serial biopsies, I would say if you know, so using T790M as the example, if we can talk about others, but using T790M as an example, if you know that T790M is there and you want to do serial testing to show that the tumor is responding or things like that, I would say we don't have any indication that that's helpful today. We know that T790M generally goes down with treatment as the tumor shrinks, as symptoms start to improve. And doing serial liquid biopsies over time does have a cost. Every test you have has a cost. I would say at this point in time, you have to stay with the same vendor if you're trying to see if there's any correlation to the one done before, because these are not apples to apples assays. The other example of doing serial liquid biopsies would be somebody who has tumor growth and maybe slow tumor growth, and you want to look for something like T790M or a resistance mechanism, and it's negative. Well, then potentially doing a different platform or doing a different one at a different point in time may be helpful. Again, I urge against a lot of those, because once you have many negative, you probably need more information. You probably need to go to tissue at some point.
I would step back and also raise the question. It is an active question of when to look by liquid biopsies. And even the question, as both Shirish and Nate pointed out, of, if we see one nodule growing or one pre-existing or one new one, we don't necessarily reflexively drop everything and change systemic therapy. I would be even more hesitant about making a change in somebody who we can't even see anything changing on scans and they're without new symptoms, but there's some change in a blood-based test. I have a general philosophy that we don't need to go looking for trouble. It will find us. And so, but I think we do run into this question of when is it too soon to make a change? And I just throw that out to say, at this point, it's not the standard of care to do serial monitoring. I think it's good to know that someone's T790M positive, or at least up until recent changes that are evolving right now about when to move later line treatments earlier. But it's not routine at this point to do those. And it's debatable whether we should, just because I think another question we need to ask is it better to leave options open for later or use your best drug right now?
As an extension, what I would say is that I think what is important to recognize is that we don't have evidence that if you started, again, going back to the T790M example, if you started Tagrisso or osimertinib at the point where you detect in the blood, even if the scans were completely stable or they were like they were before, but you happen to detect it in the blood, that starting Tagrisso at that time, as opposed to waiting till you have clear evidence of disease progression and starting it then, that you get any extra benefit. So the reason why at the present time, it is possible that in the future data may emerge that actually you're better off. Why in the light of progression are we even considering continuing the first drug in at least certain patients is that earlier starting of the next drug doesn't mean the cancer will be controlled for a longer period or will be controlled better. And so that's the point. And it is, again, possible that these data are really evolving. It is possible that in the future we may have evidence that no, the earlier you start, the better the outcome is. But at the present time, we don't have that data.
All right, so shifting gears a little bit, talking about oligoprogression. Is using radiation therapy for treating oligoprogression currently the standard of care as opposed to sort of experimental, rather than switching to the next treatment? I think this is a great question because we talk a lot about options, but what are we actually doing today? And so I would start by saying most of the data in this is actually from people who are already doing it and then publish what the experience was after the fact. And what we know is from multiple different people who've done this that you can delay having to change your treatment. We actually attempted to do a prospective trial of this between here and UNC, looking at SBRT in people with EGFR mutant lung cancers who got radiation and then continued on the treatment, and we showed pretty much exactly the same thing that we're seeing before. At least 6 months, sometimes even a year of time, you could stay on the treatment if you hit the oligo progressing. But it was very
Yeah, that's enough. Thank you.
stereotactic body radiotherapy. So this is some people call it SABR or stereotactic ablative body radiation. But essentially what it is a few high-dose treatments of radiation. I think probably the best description would be called radiosurgery. It's an ablative, potentially curative treatment for early-stage lung cancer for people who don't get surgery. It's radiation, but the chance of completely destroying every cancer cell in a tumor that is hit with this is probably 90%, so very close to surgery. But it only targets the one area that you're doing it, and it's very safe. Our experience in the clinical trial, trying to put people on this trial, it was very hard to enroll people on the trial because everyone was getting this done already. Now, like, why do I have to come there and be on your trial when I could just get this done anyway? We would even offer people, like, we would like you to be on the trial, but if you refuse to be on the trial, this is still what I recommend that you get done. So I would personally say that I think this is the standard of care for very carefully considered select people, not
not so much. I would say, one, definitely. More than that, you really have to be careful about thinking about this. I'm curious other people's opinions.
I want to comment. I would say that standard of care, yes, we think it's the right thing to do.
Right.
I would say most of our patients who have certain insurances, it is not considered standard of care on a guidelines or pathway that insurances might follow, and many patients require an appeal through our radiation oncology department. And so we do it, we want to do it, but it is sometimes a protracted insurance authorization and appeal process to get it authorized.
But I think just to underscore Nate's point that, and I think it's been addressed by several folks already, is that oligo metastatic, oligo progression, oligo residual disease, it's important to be rigorous in what that means, because sometimes I think this is an area where there's a huge difference between what we can do and what we should do. That it is technically possible to radiate 7 spots, but the biology of a cancer that has 7 spots is totally different from the biology of a cancer that has 1. In fact, once you get beyond 1, there's a big difference between 1 and 2. And definitely 2 and 3. And several of these trials are being done by radiation oncologists who are incentivized to do radiation. So, and I think they're not necessarily as rigorous as they could or should be, frankly. That's part of it is these are marketed to everybody, and everyone wants more stuff done. But it's not necessarily in a patient's best interest to have 5, 6, 8 spots done just because they could be radiated. That makes it incredibly more likely that this is a whole body problem and that there's others beyond that. If you have 1 spot, well, then that could be the one that got away. Beyond that, it's much more likely to be an issue where the invisible disease is increasingly a problem, not just the visible.
I would just add that, to follow up Karen's point, is that where I think it is quite standard is oligoprogression in the brain, or CNS, central nervous system, and there, so having a single spot of disease arise just in the brain on a targeted therapy, for example, I think that's fairly standard to treat that with radiation, typically stereotactic radiosurgery or gamma knife. And there, we know, for example, certain of our targeted therapies aren't the most brain penetrable. Many patients are still on drugs like crizotinib, for example, where we often will have just oligoprogression in the brain. And I think they're using focused radiation to treat that solitary brain lesion would be viewed as standard.
So I'm going to ask a question online. I'll invite our online audience, which is a large group, to ask your questions through email, targetedtherapies@cancergrace.org. I'll also emphasize, you can see there's a pretty big pile of questions here. I've got a bunch online. Fortunately, we have the extra time of now in addition to a big chunk of time in the next session. So we aren't going to get to everyone's card-based or email questions right now. We'll get through as many as we possibly can through this session and the next. But one is, should we be treating areas of progression differently based on site, like liver versus bone? But I would also add brain. I mean, in general, I would say no, but brain is kind of considered a separate entity, because in many cases, it's not that the drug is ineffective and there's true resistance. It's that the drug may not be getting into the brain as well as it gets into the body. So I don't know if you all have different views on thinking of progression in the liver versus bone versus adrenals differently. I would say generally not. But the brain is considered a special case because many of our whole body therapies don't get in the brain that well. There's more limited real estate there, and so we really do prioritize sometimes local therapies, thinking that, well, the current oral therapy you're on is doing a great job for the rest of your body, but we may need help in the brain. That said, many of our most effective newer therapies, and that's for ALK, ROS1, and EGFR, these second and third generation agents also have better intracranial activity, and we are moving to an approach like the case you mentioned of trying to avoid brain radiation at all if we can, and many of our newer oral therapies allow that. It didn't used to be an issue we had to think or worry about that much about because unfortunately people weren't living long enough to have side effects of brain radiation. But fortunately we have the new problem of people living for years and years after with these new treatments, and we would love to avoid brain radiation for the complications it could cause 2, 3, 4, 5 years later if we can. So it doesn't mean it's not appropriate for, it might be the right tool for the job, but if there are oral drugs available that can take care of and neutralize the threat of brain metastases, anything we can do to avoid even focal radiation, but especially whole brain, is a welcome change. Other thoughts?
Just was going to highlight a case as Jack was speaking of a patient of mine, again, started on EGFR exon 19 deletions, had started on afatinib, had extensive disease in the liver, in the bones, in the lungs, and on a brain scan had 2 very tiny spots. So we started her on afatinib and did not treat the brain lesions. The first scan after 6 weeks showed that the 2 spots were no longer seen, and a wonderful response in the rest of the body. She was doing very well. I was extremely glad with how she was feeling. And then I was doing brain scans fairly regularly, and then in July, her scan showed just multiple brain mets. She was feeling great. They were all very tiny. But I felt there were just too many. I did consult a radiation oncologist, and we reached a point where many lesions now can be gamma knife, but this lady just had too many lesions. And I switched her to osimertinib. I did not have a T790M result. And on osimertinib, her brain scan has shown a complete response, and the rest of the disease continues to be under control. She was very troubled when I switched her because she says, "Why are you switching me? Considering that I don't have, you didn't check for T790M." And so the reason her tumor progressed in the brain was not because the tumor had developed a T790M mutation, but more because afatinib was not reaching in sufficient amounts in the brain and was controlling the brain, whereas osimertinib manages to reach the brain. I'll admit that insurances may not allow osimertinib if you don't have the T790M result. Fortunately, in this patient, it was allowed, and so I was able to spare her whole brain radiation, and now we're going to continue her. So what I'm just saying is we do view these progressions in different fashion, and yes, we could use different treatments, including going to a drug like osimertinib, which right now at least is approved for second-line T790M positive patients, just because this patient has brain lesions.
Just as a global announcement, I'd encourage everyone to use the marketed names, not because we're marketing the drugs, but because we again, this is one of the jargon things. There's a reason why they have names other than osimertinib and whatever, and they're more accessible to you. So I would encourage us to relax that this is not a CME event. And we just want to make it as easy for you to follow this as possible.
I would say that the brand names have actually gotten almost as confusing as generic ones now.
They tend to be easier to pronounce, too.
So actually, 3 separate people asked the same question, and I think it's important to just get an answer from our faculty here because I think it is something very common. And so we're talking about liquid biopsies and monitoring things, but in fact, for decades, oncologists have been using a form of liquid biopsy to monitor what are called tumor markers to monitor patients with lung cancer. And so the questions are all one variety or another of how valuable is it actually monitoring traditional tumor markers like CEA in patients with lung cancer who are on targeted therapy. So anyone want to take that?
We don't want to take that because we don't think it should be done. I don't know how to put it in a proper sort of fashion.
Well, I would say it's not. It's a theme that has come out, and that is that there's a distinction between any detectable hint of progression if you torture the information enough versus what is clinically relevant. Now, CEA and other tumor markers have not been broadly used. They certainly are used by a subset of doctors, but they tend not to be because lung cancer is easy to follow on imaging generally. And I would say that, just like Nate said, if you have to squint to see the progression, it's not enough progression to really change. I would say if you have to look at a blood test and can't see anything more obvious than that, that's even more irrelevant to me. So I just don't think that, to me, it might be a useful thing to consider if you're going 6 months between scans and you want to check at 3 months to make sure that it's not on the rise, or you might change the schedule of your imaging. But I don't do it as a rule. I think that most of us don't. And it's largely because we don't want to overreact to a 1 or 2 millimeter change on a scan. This is even less relevant to me than that would be.
Right. Yeah. I mean, one of the overarching messages from this morning's session was what we care about is the person sitting in front of us and whether they're truly getting better or getting worse. So we care about how they feel. Are they feeling worse? Are their symptoms getting worse? That's something we have to do something about. Are the scans actually showing their cancer getting bigger or getting smaller? That's something we can actually objectively see. Some of the blood tests are even telling us, yes, there's something about the cancer that's changing, and maybe we should think about it, but it still has to be in the context of what they're doing. Then there's all these other non-specific things. So I would put in the category of tumor markers, even changes on PET scan avidity of the brightness of the lesions, whether they're not getting bigger and the patient's not feeling any worse. These are what we call non-specific, which means they may have nothing of importance to the patient's life or whether their cancer is getting better or worse, but they can still go up and down, and we don't know what that means. And so if it's not affecting how they feel or whether the cancer is physically getting better or worse, most of the time it's better not even to know that something is changing, because all it does is confuse you and make you worry.
And there was a question that came in online as well that asked something you alluded to, that is about, is it better to do serial PET scans than to do CAT scans? Are CAT scans good enough? I would say that ASCO, which is the American Society for Clinical Oncology, which is the most influential professional group that we are all part of in the U.S., has a campaign called Choosing Wisely that tries to emphasize practices that they think are wasteful, that oncologists should not do. And one of the tenets is stop doing so many damn PET scans because they're hugely expensive and they can lead us down rabbit holes of lots of things that we end up chasing down when we do a colonoscopy because something lit up a little bit in the colon, but at the same token, seeing the SUV, which is the standard uptake value, the metabolic activity of a cancer you're following go from 5.9 to 6.5, if it hasn't changed size and you're feeling just as well, is not a relevant reason to change. But it too often leads to a reflexive, oh my God, the sky is falling, we need to change everything. And so I think that's something that should be done a lot less. We routinely do PET scans early on to get a sense of the lay of the land, where it is and where it isn't, but not every 3 months to follow things. I don't know if others have different views there.
Well, I would just say that there's nothing more frustrating than a second opinion consult and seeing somebody's gone through 2 or 3 or 4 therapies and all of the changes were based on either CPA or changes in PET. Mm-hmm. And I see that frequently. And it's really because lung cancer has evolved so much in the last year, 2 years. It's hard to be a generalist and do everything. And so when you're getting PET scans and CEAs and all of those, and people are just looking for a marker to change, and then you change, you're running out of therapies. And so I know that having lung cancer, metastatic lung cancer, is an incredibly anxiety-ridden state. And you want as much information as you possibly can because you don't want to
miss out on a chance that's going to help you live longer or fight this disease better or something. And everybody wants that chance. And so a CEA is a simple blood test. You can follow it. You can chart it over time. And so people want that. But for the most part, it's anxiety-provoking in everyone. It goes up a little bit. You feel like the sky is falling. And so not testing it is much better. It causes so much anxiety. It is really my least favorite test, and then the second one would be the SUV. And so less information or more information is not always better.
I think one of the key points is it is wonderful that we have so many new treatments that are coming out, but we don't have so many that we should be in a hurry to exhaust ones that are still active. I think that one of the things that I'd like to throw out as a whole general principle, but I think that we should do after Alice's talk in the next session, is the global question that we have some newer therapies that are more active iterations. We also have people doing very well on first generation EGFR inhibitors or ALK inhibitors, and in fact, Dr. Shaw has presented and published as the first author on some of the very pivotal things like the ALEX trial that we'll be thinking and talking more about, showing that alectinib or Alecensa, a newer drug, is clearly more active. But should we change at the first opportunity or not? And how valuable is it to have something in your back pocket? We have generally favored, it's always nice to know that there's something backup waiting in the wings. But with Tagrisso, we now have a trial pretty similar to the ALEX trial, suggesting new may be better, maybe way better, but is it better to sequence options or is it better to go with your best up front? And I don't know if I think we are all going to be wrestling with this question because we're all seeing patients in our clinics doing well on some of these earlier agents. You're many of them. And I don't know what your views are about, do you just want to be on the drug that has the best overall control, especially brain, which may be a bit of an Achilles heel
I can
for some?
tell you that it's one of the most talked about topics on the social media
and it should be, because I don't think there's an answer that comes down from God on this, and it's one that we struggle with, and there are merits to both sides of, having something. I have patients who are doing well for 2 or 3 years on a first generation EGFR inhibitor, ALK inhibitor. I know you do. We all do. Should we take our patients off when they're doing just fine, just because of these data, or should we reserve something? I think that's probably a bigger question than we can tackle right now, but because we should go for a break, I think. And
we have like 3 more minutes.
Okay. But I would encourage everyone to think about this because this is something that we're going to want to talk more about.
This is one question I wanted to get to because I think this is really important, the difference, again, between your academics talking and the actual patients wondering about this. We've been talking all about efficacy and progression, but this question is, what about quality of life and side effects from the treatment? Does that factor into whether you should continue or switch to something? And I think this is a very relevant thing. Alice?
Yes, actually just to follow up on Nate's point, I think that was kind of the theme as well of what we were saying about really it's the patient in front of us that we were treating. And, I think you said it really, really well, Nate, earlier when you're talking about we don't take numbers or, just the simple scan results by themselves without incorporating how the patient is doing as well. So I think that is, just a really important point that for us, the goal is both to treat the cancer, control the cancer, prevent complications, but also to maximize quality of life for patients. I think that is equally important to controlling the cancer. So I would say, yes, absolutely. If there's a great drug, even like alectinib, which we know is generally well tolerated and works great, but a patient isn't tolerating it, and I've had now a number of patients who for some reason just cannot tolerate alectinib, and they're not doing well on it, they're not doing their normal activities, they're not able to get their work done, and for those reasons, meaning we're compromising their quality of life, we will often think about either adjusting the dose of the drug, which is a very effective maneuver for some patients, or we will actually have to sometimes think about switching.
Yeah, I tell people right up front when we start on this drug, because a lot of people want to know, how long am I going to be on this? Am I going to be on this for 6 months or whatnot? And I say, we're going to keep going as long as it's working and as long as you're happy with how you feel on it. Because if we can't make you feel like you're living a normal life or a life that's tolerable to you, then we need to change what we're doing.
I think it's even more important with targeted therapies than most other things, because our goal is to have it be a longitudinal therapy. I mean, we and you are desperately hoping it's going to be something to be on for months to years. But particularly when there are many choices, and increasingly there's multiple EGFR inhibitors, there's multiple ALK agents, and ROS1 as well, growing data. So it's great to have choices. I think it's very important to think about that intersection between efficacy and tolerability, because some of them do force Sophie's choice of maybe a little better efficacy at the cost of tolerability. And I don't want, most of my patients don't want to be wondering, is it worth doing this one more day every time they're taking this? I think that we really want something that is easy to take for as long as possible.
So I think we need to take a break at this point. We're going to reconvene at 10:30. Please come up and talk to the faculty, ask them questions. If you need the bathroom, it's right out to the right, and then it's on your left.
And we'll have more questions. We have another panel online.
Families, I think they were in Russia that are all German teachers.
The average is.
So, Jeff, you come to okay. I would say
Yes, that's cool. I'm not sure, but it knows. Let us free choice. It's like people say, go to it's got the reputation. I don't know. Go wherever you want.
So I guess everybody.
No. They have to actually validate it. So
He wants money. That's the stuff. Hopefully they're still around. He wants money. So let's go out. His name. It's over. His name is up.
Okay, folks, if people can get their seats. If people can take their seats, we'll start the next session. Okay. Nate, jump so far. I think that's the Q&A. Okay. Okay.
How long for you guys? I got 5 years.
Oh, there you are. Are you going up? Oh, you're on an album?
We're going to start the second session, which will take us through to lunchtime. I want to thank many people. First, I would like to thank everyone for coming from sometimes considerable distances to come here. I hope you find it very worthwhile. There's relatively limited opportunities for people to meet so many other people with the same uncommon to rare mutations and facing so many of similar issues. I mean, these are geographically relatively limited, so that if staying within your city, it's not that easy to connect with so many people who have the same mutations and facing the same issues. And I know many of you have probably connected with each other online. I think it's amazing to connect with people who you have only known virtually. I really want to thank Dr. Nate Pennell, who, as he mentioned, has really been part of GRACE for about as long as anyone other than me and very few other people who were there from 2007. 2008, Nate really just got it. And I remember that dinner at ASCO and how great it was to talk with him about this. And very shortly thereafter, he was a frequent contributor and has always been a champion. And literally today wouldn't have happened without him. I want to thank him and the Cleveland Clinic Foundation for hosting today. So thanks so much. I next want to introduce again Dr. Shaw. Dr. Alice Shaw has been essentially synonymous with the field of ALK and ROS1 since they became entities that we would ever think about. But she certainly was a renowned great doc before that. I went to Harvard Medical School. She went to Harvard as an undergraduate, then Harvard Medical School, saw my MD and raised it a PhD, so she had both. And then went on to the Harvard Dana-Farber fellowship program. So she's what we would have referred to as a complete preparation H. And I mean that only with love. But as I said, since then she has been just setting the pace for the field of ALK and ROS and does other work as well, but is extremely generous with her time with patients and with the rest of us. And so I thank you for making the trek out and being part of this. And she is next going to be talking about clinical trials. But before I do, let me just make a couple of announcements. One is that our sessions are being recorded, and we will send links later this week or in the next coming days, both for the online folks and for you to catch anything. I know there's a lot going on, but you'll have other opportunities to get it. The presentations are and will be available online. And so, in addition, we're going to be doing another Q&A session right after Dr. Shaw's presentation. We'll pick up on many of the threads that people have submitted. They're right here. I've got them online as well. But you can submit others. If you're online, send it to targetedtherapy@cancergrace.org. We will be stopping at noon, and we're going to have a lunch on the first floor from noon to 1. So, and at that time, it's going to be the tables. Tables will be set up with different faculty names there, so you'll have the chance to sit down and talk with us, ask questions, and chat about whatever. So that's it. Without any further ado, thank you, Alice, for being here.
Thanks, Jack. I don't know how to counter that preparation H comment, so I'll let that lie. Of course. But thanks to all of you for coming out here and, on your weekend, coming here to learn and to advocate for yourselves and for other patients as well. Of course, thanks to Jack and Nate, as well as Carly and her whole team. I mean, this really is an amazing opportunity for all of us to meet and discuss, I think, some really important topics in lung cancer. So, let's see. I was asked to speak about clinical trials, and I actually realized that this was going to be a bit of a challenging topic because the audience, you guys are so diverse. I know some of you have been on multiple different trials, phase 1 trials even, and some of you may have been on some of the same targeted therapies but never been on a trial. So I know that this will be a bit of an overview. Maybe you guys, some of you will know everything I'm saying, and some of you may actually learn a little bit about clinical trials and why they're so fundamentally important to our progress in this field. And I wanted to open with a case, mostly to start us all thinking about why are trials sometimes problematic for us, for patients, for caregivers, for the doctors themselves. And this case is a real patient of mine, and I think it's been a while. I first met him maybe about 5 years ago, but his case has really stuck with me because some of his perceptions of clinical trials. So this patient, he was diagnosed with metastatic non-small cell lung cancer in January 2013, although he had been having symptoms for several months leading up to that. And at the time, we were already doing molecular testing, so he was diagnosed and found to have an ALK rearrangement. As many of you know, this is a very good result when we find a driver, especially one like ALK, where we have many different targeted therapies. And so crizotinib was already approved, Xalkori. It was the first ALK inhibitor tested in the clinic. It was approved in 2011. This was something now all the oncologists could prescribe for a patient like this. So he went on to Xalkori, did very well, but his response lasted only about 5 months. And at this time, he had worsening disease, including worsening symptoms, and we recommended that he consider the newest ALK inhibitor that we had at that time, which was actually ceritinib, Zycadia. I have to think of the brand name. And this was actually in a phase 1 study at the time, but actually had moved very quickly in phase 1 and was already in what we call the dose expansion portion, which means that every patient receives the drug and receives what we believe is the standard dose of the drug. But it was still in the context of the phase 1 study. And remember, at that time, we didn't even have the name ceritinib or Zycadia. It was actually called LDK-378. So we offered him this phase 1 study of LDK-378, and we already had preliminary data. I think we already even had presented it showing that this was really an active drug in patients after crizotinib. This is the first second generation inhibitor, and we were really excited that we were finally, we were seeing some good results. We explained all of this to him and recommended the phase 1 study, but he really refused to participate. And this was a lot of conversation with him about why he wasn't interested in participating in this trial, and he really had this fear of phase 1 trials. He really felt like phase 1 meant that we were guessing, that we were experimenting, and he did use the phrase that he was going to be a guinea pig in this experiment of ours. So he had very, very firm, preconceived notions about what a phase 1 clinical trial meant to him. And so, in fact, despite our recommendation to try yet another targeted therapy pill, he actually opted to go ahead with standard chemotherapy, which I should say, as you've heard from the other speakers, is absolutely fine to use. We use chemotherapy for our patients, and it can work really well, as you've heard. So that was an acceptable, certainly a perfectly acceptable choice for him, and he actually did pretty well on it, probably for about almost 6 months, about 5 months as well. And then when his disease progressed after the chemotherapy, now we had our second generation inhibitor in the clinic. This was now a phase 1 study of Alecensa. And also, again, the same issue that we had moved very quickly in phase 1. We weren't guessing on the dose. We weren't really guessing on much. We had seen great activity, explained all of this to him, and again, would not budge from his worries about the phase 1. And so instead, actually, what he ended up opting for, and you guys might find this interesting, is we actually at the time had opened a phase 3 study of Zycadia. This is the phase 3 study randomizing patients to receive either Zycadia or standard chemotherapy. And I would say, and I know these guys think that many of us don't like those studies of randomizing patients with targets and to an actual half of them would receive chemotherapy. And so, in fact, even though this was an option, we really were recommending the phase 1 study of alectinib where we knew he would get the drug. But, again, his perception of trials was that if it had gotten to phase 3, that meant it was advanced enough, we weren't experimenting as much, and so he actually really wanted the phase 3 study of Zycadia. So he enrolled on that and actually got randomized to the chemotherapy arm of docetaxel, which was very sad to us. He understood that that was a risk, and he was okay with it because it was in a phase 3 study. So unfortunately, though, he had a lot of difficulty. Some of you may have been on this chemotherapy. It's called Taxotere, docetaxel. It's a tough chemotherapy. It does have very limited activity in patients with lung cancer, including ALK. And he actually could only receive 2 doses before he discontinued for toxicity. And so finally, though, after he discontinued due to the side effects, he had some worsening disease. We were finally able to get him onto Zycadia at this point. And now he's actually been on Zycadia for 3.5 years with a great response. And so this story worked out okay for this patient. He got to a drug that's really effective for him. Chemotherapy helped him to get to that drug, I guess I would argue. But he also could have been on that drug much earlier. Again, just to emphasize, phase 1 trials, yes, it's a new trial, it's a new drug, but we're not always guessing. We're often not guessing, I would say. And oftentimes, that's the best way to access a really effective drug.
Okay, so we'll come back to this case, I think, toward the end and certainly maybe in our panel discussion, but just wanted to start sort of the discussion on clinical trials with that. So here is a slide summarizing what we often call our traditional, sort of the traditional process of developing drugs, especially cancer drugs. And I just wanted to give you a sense of the timeline of this in sort of the old days. So you may know that lots of work is done by many, many people, often in pharmaceutical companies, the medicinal chemists, the structural biologists, the pharmacologists, to work on a particular target and try and develop a targeted therapy. And that phase of what we call discovery can go on for years. I would say it often is many years to go from, for example, knowing about a target or having a good targeted therapy that you're trying to really characterize well prior to the clinic. And then as it's looking promising, those lead compounds is what we sometimes call them. So the most promising drug candidates will move into preclinical testing, often testing in not like just cell lines, but also now testing in animal models, trying to fully characterize the toxicities that may arise from the drug. And again, this can also take a number of years to do. And then once all of that happens now and the drug looks pretty clean in terms of side effects in preclinical testing, then that drug will move into first-in-man, or what we call phase 1 clinical trials. And those studies, I would say, typically might last, say, on average, a couple years, probably 2 to 3 years in the phase 1 setting. We'll talk about what each of these phases means in just a second. And then that often is followed then by a phase 2 study, again going on for a couple more years, now really honing in on how active is that drug in the patient population of interest. And if that's looking safe from the phase 1, active in the phase 2, then you can think about what we call sort of the larger phase 3 studies, which are often the randomized studies trying to show superiority of the new drug over what's viewed as standard of care. And again, that can also take a number of years. And so again, in the old days, this process would typically, you can see even just a clinical testing portion of this to go from phase 1 to FDA approval could easily take 8 to 10 years. And of course, all the years before that of doing the discovery and preclinical testing. So you can have a lead compound from the company and it won't go to FDA approval for over a decade. So that was how we often developed drugs in the past. And fortunately, as many of you know, I would say in the cancer field in particular, this process has actually now been shortened. And so this is an example of crizotinib. Some of you have been on crizotinib. I have many patients who are on the original phase 1 trial still today, but just to give you a sense of how much faster we can now make this process. So the drug was first synthesized at Pfizer in 2004. Phase 1 trials, the first-in-man study was initiated in 2006, even before we knew about ALK or ROS1 as a target in lung cancer. Then ALK was discovered as a target in 2007, almost exactly 10 years ago. And then once that happened, where we had potentially a targeted therapy already in phase 1, we had a target as well, and a target population, we could move very quickly in that phase 1 trial to now test the drug in the correct population of patients, again, all in the context of a phase 1 study. The activity of this drug came out very, very quickly. You guys know how quickly these drugs can work. So even with the very first patients who enrolled with ALK-positive lung cancer on crizotinib, we knew within about a week that this patient was already responding to the drug. And then you can imagine a couple other patients after that, and it was pretty clear this was going to be an effective targeted therapy for ALK-positive patients. Based on the phase 1 data, we moved very quickly to both phase 2 and phase 3 trials, which were initiated simultaneously. And with the phase 1 and phase 2 data alone, we were able to actually submit the application to the FDA and obtain accelerated approval of crizotinib for ALK-positive patients in 2011, which was really only 4 years from the beginning, from the discovery of ALK as a target. So again, a much more compressed timeline in terms of our ability to have new drugs and move them quickly through phase 1, 2, and even retesting. This has happened now more than once. This is certainly not a unique example anymore. All of us are familiar with other drugs that have also moved very quickly. Zycadia, Tagrisso, the immune therapies, many of these drugs have also had very similar timelines now where we're actually able to move a drug from phase 1 into sort of the approved landscape of therapies in about 3 to 4 years. So much better than what we've done historically. Okay, so let's talk a little bit about clinical trials. And again, this is going to be an overview of what clinical trials are. And if any of you have been in them or if you're contemplating them, hopefully this will help you understand sort of certain aspects of these trials and why they are so important. So just as a general sort of definition of a clinical trial, and I should say that many of my slides, I was fortunate to work off a slide set from Pat LaRusso, who is at Yale and is a developmental, does a lot of drug development, and so thank you to her for sharing some of these slides. So clinical trial, it's a prospectively planned study. That means we're starting patients on a treatment, we're following them going forward in the future. And the reason we're doing this is to evaluate the activity, the safety of a new treatment. And we want to conduct clinical trials under the best controlled conditions as possible so that we actually have real, I would say, definitive answers to our questions about how active and safe the drug is. And really, like I was saying earlier, clinical trials are the best way that we have, the most definitive way we have to show whether or not a new drug is active or not. And as I said, these trials are really, really critical to establish the safety. You know, what are the side effects? What are the potential complications of these new therapies as well? We have to be able to capture those in a very controlled way. So what's a phase 1 trial? I've already talked about some of the phase 1 trials that have been performed recently. As I said, these usually refer to drugs that are now being tested in patients for the very first time. So you'll also often hear us refer to them as first-in-man studies. And I think what's a little bit confusing sometimes is that really the primary objective of a phase 1 first-in-man study really is to define the side effects of a drug and what the best dose of the drug is. And we define the best dose based on the side effect profile that's seen at each of the dose levels that we're testing. And then secondary objectives of the phase 1 trial are to study some other aspects, again, important about the drug. So pharmacokinetics, meaning what does the body do to the drug? And really oftentimes when we say pharmacokinetics to you, you guys often hear us say PK. We're often referring to drug levels in your bloodstream. So how much drug is actually, with a given dose that you've received, how much drug is being exposed in your bloodstream? And we also often like to know pharmacodynamics. Is the drug acting on the body the way we think it should be? So if it's an ALK inhibitor, is it really able to turn off ALK? And then another secondary objective is actually now the efficacy. Can we get a glimmer of how active the drug may be? And what I want to just point out, though, is that people are often surprised about this, that the efficacy or the anti-tumor activity is really a secondary objective of the phase 1 study. Again, the primary objective of these studies is to establish safety and dosing. And most of our phase 1 studies want to find what we call the maximum tolerated dose, and then that often leads us to then define what we call the recommended phase 2 dose, or what usually turns out to be the standard dose once the drug is officially approved. And so just to give you a sense of what a phase 1 study might mean, and many patients ask me about this because we often, again, as Jack was saying, we have so much lingo. You know, we talk about slots, we talk about expansions, and it's really hard to know what does that actually mean. So this is an example of when we're talking about why there may be limited slots or why we may be at a dose level. This is an example of how a phase 1 study sometimes is run. And again, we're looking to typically test different doses of a new drug to find the maximum tolerated dose. So here's an example of what we call kind of a typical 3+3 dose escalation scheme, where we start by enrolling 3 patients, first at the lowest dose that's been identified as most likely safe dose. And we follow those 3 patients, usually for a period of time, usually about 4 weeks. And we follow them for side effects. We follow them also for the drug levels in their bloodstream. And if there are no significant side effects, then we feel, okay, this dose has cleared for safety, and now we can go to the next higher dose. And then we continue along those lines. And at some point, in every phase 1 trial, almost every phase 1 trial, we do usually come upon a dose where we now do have more significant side effects, and at that level is where we start to explore more, potentially enroll patients, have more slots for patients, so we can explore more that particular dose and see if those are true side effects that are now going to define the highest dose possible. So just a little more detail there about how we then determine if we should keep going further on the doses or if we have to back off. But I think my point in showing you this is it's pretty complicated. We don't have usually in a phase 1, because really the primary objective, as I said, is to determine safety and dosing, and really our priority is to make sure that patients are safe on this new drug. And so that's why we do take the time to explore these different dose levels one at a time, rather than just allowing any patients to enroll at any of these doses. So it's a very, very, I would say, sort of critical step in terms of developing drugs, is to know what we're dealing with in terms of safety and to identify the proper dose for patients. And so again, I'm going to give you a couple examples as we go through what clinical trials are. Here is a complicated looking slide of the phase 1 trial of Xalkori. And I'm mostly just highlighting, again, the point that there are these different cohorts. We started with cohort 1, the very first dose level. It's a very low dose of Xalkori at 50 milligrams once a day. And then you can see that as we cleared cohort 1 with no side effects, then we moved up to cohort 2, was double the dose, and so forth. So again, each of these step-ups usually takes at least a month, usually a couple months, to make sure we've cleared each of these doses for safety. And again, our goal isn't to look and see, how active is the drug, but we do like to see that as well. So many patients they're all getting their scans as usual, and we are looking for any signs of activity, often even at these early stages of a phase 1 trial. Now, the other thing that's a little bit complicated to people about phase 1 trials is that they've gotten more complicated in their design. So it's not simply different doses and establishing safety, but also once we get to a dose that we feel pretty confident about, we think it's a safe dose, we haven't seen too many side effects, then oftentimes what we do in the context of this phase 1 trial is we enroll a lot of patients into that dose, and we sometimes call that dose expansion. And so, for example, for the crizotinib study in ALK-positive patients, also the crizotinib study for ROS1 positive patients, they all came into this phase 1 study, but in expansion, where every patient got the standard dose of Xalkori, which you know is 250 milligrams twice daily. And then, of course, that data, together with the phase 2 study of Xalkori, is what led to FDA approval. So now what about the phase 2 trials? So here, again, the overall objective of a phase 2 is really now to focus on efficacy. How active or effective is the drug in controlling the cancer? And usually, of course, we try and focus in on a population of patients for whom we think the drug is going to be most active. So, for example, for Xalkori or Zycadia or Alecensa, we're focusing in on the ALK-positive patients in the phase 1 and phase 2 studies. Phase 2 studies are also important in that they give us a lot more data on safety as well, because oftentimes the phase 1 studies have moved quickly. We've had, 3 to 6 patients at each dose level. We may not have a huge number of patients in the phase 1. We tend to have many more in the phase 2 because we want to examine efficacy, but we also want to have a much clearer view of the safety profile of the drug. And then some of you who have been on phase 2 studies know that they can be designed different ways. They often are what we call single-arm studies. What does that mean? That means every patient who enrolls is in one group. They receive the drug at the standard, or what we call the recommended phase 2 dose. But sometimes we can have somewhat more complicated phase 2 designs where, again, the focus is efficacy, but we might be examining different doses or different schedules of the same drug. So to give you an example of a phase 2 trial, this is one of brigatinib, is that Ellenbrigg? Ellenbrigg. So this is a phase 2 study of this second generation ALK inhibitor. And again, just to highlight an example of how one of these studies can be done. And in this particular study, the authors wanted to look at 2 different dosing regimens of Allenbrig. And so one dosing regimen was at a lower dose of Allenbrig at 90 milligrams. The other arm, or the other group of patients who came in, received a higher dose of the Allenbrig at 180 milligrams. And again, focusing on how active are these 2 different doses of the same drug. And this is a slide summarizing some of the data from this phase 2 study. These are the waterfall plots we talked about last time. A waterfall plot for the patients who came in at 90 milligrams, a lower dose, versus the patients who came in and ultimately received the higher dose of 180 milligrams. Remember, all those downward bars in these waterfall plots indicate individual patients' tumors shrinking in response to the Allenbrig. You can see that at both doses, the drug was very active because there's so many downward bars in each of those waterfall plots. And then what I've indicated there is MPFS, is median progression-free survival, which is kind of a rough estimate of how durable, how long these drugs work for. And what we could see in this randomized phase 2 study is that the higher dose of Allenbrig at 180 milligrams likely leads to more durable responses to this drug. So this study was both able to examine efficacy and also able to define the standard dose of, and the standard and most active dose of this ALK inhibitor. Okay, let's just move to phase 3 clinical trials now. And here the overall objective is now to compare experimental therapies, your new drug, with what's viewed as standard of care therapy. And many of you may have participated in these. These are typically randomized controlled trials. And again, traditionally, these trials have been kind of required by regulatory agencies for a drug to get approval, and typically even now for what we call full approval by the FDA, meaning that the drug is viewed as the new standard of care. And these are really important studies to do because here we actually have the same population of patients. They should really hopefully be pretty much the same. For example, ALK-positive patients. And really, they're randomized to one or another drug, either the experimental or new drug versus the standard of care drug. And really, that's the only difference those patients are seeing, that is the difference in the treatment they've received. And so it really allows us to focus in on the comparison between 2 different drugs. And I would note that the control group usually does receive what's viewed as standard of care. So, for example, my patient who was randomized to chemotherapy, he received Taxotere because that is viewed as a standard of care second-line chemotherapy. And these days, we really don't do what many of you have heard of as placebo-controlled trials. Patients are randomized to receive, a placebo, meaning no active drug. We really have moved away from doing trials like that. And of course, that raises all sorts of ethical issues if you were to randomize patients to no active therapy. So I want to give you an example of a phase 3 trial. Many of you have heard about this. We briefly spoke about it already, and Dr. Gadgeel will talk about it more in the ALK session, which is the global ALK study. This was the phase 3 randomized controlled trial comparing a second-generation inhibitor, Alecensa, to the standard of care first-generation drug, Xalkori. And so you can see sort of the overall patient population that comes in. Again, patients have to meet certain eligibility. We want kind of a homogeneous population of patients. They are randomized equally, one to the alectinib or experimental arm, one to the control arm. And then we're looking at a number of endpoints to determine whether or not the new drug, Alecensa, is more active than the standard of care. And also, we use these trials to compare safety and tolerability. And we had also briefly talked during the discussion about quality of life. And these randomized trials often give us a view into how patients view their experiences on these different drugs. And so just to summarize at a high level, this is one of those complicated plots, again, that we often look at in oncology, but this is what we call the primary endpoint of a randomized phase 3 trial. In this case, it was progression-free survival, how long patients were continuing on the drug without evidence of worsening disease. And as Jack was describing, typically we see these curves coming down. It gives you a sense of the progression that patients were experiencing over time. And as Jack was describing, typically we're looking for a separation of curves, and the curve on the top is usually the curve that is indicating the patients who are doing better. And so what you can see here is that that top curve for this study was Alecensa. So Alecensa was clearly shown to be superior to Xalkori as first-line therapy for patients without positive lung cancer. So just to summarize where we are with clinical trials. So clinical trials, as I was saying, they really are essential. It's our only way to bring new drugs to patients, is to test them not just in the lab and in animal models, but we have to be able to test them in patients so we know that these drugs are active and safe. They really are essential to cancer drug development. As I mentioned, phase 1 studies establish safety, the dose of the drug, drug levels in the bloodstream, and also give us a sense usually of how active the drug may be. The phase 2 studies really confirm how active the drug is, also allows us to gather more safety information, and often we can do what we call correlative studies, which is try and understand who's responding well to the new drug and who may not be responding as well. And then the phase 3 studies are our large randomized phase 3 studies that really are important to show that any new drug really is superior or at least comparable to what's viewed as standard of care, and to look at differences in toxicities or side effects between two drugs. So I just want to end on this before we switch over, and this is always shocking to me when I see this number. In the U.S., it's only a tiny fraction of patients, 3%, of patients who have cancer who participate in clinical trials. So I ended with this because I think our first patient, fortunately, he was able to get access to Zycadia, but I think some of the barriers to trials do include patients' perceptions on trials, but there are many other barriers to clinical trials as well, and I think we're going to probably have a discussion about that in just a few minutes. So thank you very much.
So I'd like to thank you so much for that. I'd like to reconvene the panel and also add several of our patients who are going to be co-leaders of our sessions this afternoon to join us up here. Let me just start with a couple of comments and thoughts with regard to Alice's presentation. One is that we do sometimes still use placebo in certain settings, and it isn't necessarily anathema. It's not a crime against humanity. It's just we would never want to ethically do a study where anybody gets a risk of getting a treatment that we know is inferior. So sometimes a placebo arm there may be a placebo instead of a new drug being added to a standard. So one of the questions.
I should clarify that.
Yeah.
As an example of what Jack's saying, we have, for example, there was a trial many of you have heard about where it was chemotherapy plus or minus an immune therapy, pembrolizumab, Keytruda. And there was a placebo arm in that trial where the patients who they would have received chemotherapy, which is standard of care, plus placebo, not the immunotherapy, versus the experimental arm that got both. But I think my point, Jack, sorry if I wasn't clear about that, is that patients are going to receive typically some therapy, and there may be a placebo with it,
right,
but they're not going to receive placebo alone typically,
right,
where you have no active therapy.
The only time when that might happen, and frankly it's hard for us to do in the U.S. at all, is when there is no standard treatment, and the standard might just be focusing on comfort and supportive care. And those are typically later, after you've done 2 or 3 or 4 treatments. If we have nothing good to suggest as an alternative, it might be some patients get a treatment and some don't. In the U.S., one of the challenges is, many patients do not want to do this, or So that is a limitation, but sometimes it's valid and valuable to look at a placebo because an investigational treatment may be worse than nothing. And we have examples, humbling examples that we've seen in lung cancer or other settings where we would never have known that a treatment that we might have adopted without studying it further is actually worse than doing nothing if we hadn't done a placebo. So sometimes the placebo arm is the group that does better. The only way we can ever really know is to do a study to ask it appropriately. So it sometimes is the case, but we are very mindful of not wanting to ever assign people to a treatment a possibility that is less than the best thing that we think we would want to do outside of that trial setting. The other comment I wanted to make, and I'm interested in your thoughts on, is Alice highlighted the story of ALK and crizotinib, which is really remarkable and inspiring for many of us, because it really highlights the different world we live in with molecularly targeted therapies. There used to be, at the time that many of us started, the standard was chemo doublet plus or minus new drug in an untargeted population. And the trials were hoping to see a difference of 6-8 weeks in survival. And they often fell short, and it was just a gunshot approach to everybody. And it was really not ever worth sending a patient on a plane for a trial that was aiming so low. The world is totally different with these trials, particularly phase ones. In a world of targeted therapies, narrow populations, we never ever saw response rates more than 50%. And it became self-evident that these drugs were amazingly effective. I mean, ROS1 became a relevant target, and the crizotinib widely used based on essentially case reports, very small series, but you didn't need to run a 700-patient trial when you saw amazing responses. And Dr. Ross Camage, who's already been mentioned this morning, from Colorado, and I wrote a paper a few years ago, an editorial in the Journal of Thoracic Oncology called Have Mutation Will Travel, just talking about the new value proposition of if you have a narrow subset population with a target, and there's a therapy that has a significant potential to be better based on lab-based work or the first couple of patients, it's all of a sudden way more worthwhile for me or you to think about, go where that trial is, because it's not a subtle minimal benefit. It's often a huge benefit, and many of us have patients or are patients who have been recipients of some of these early treatments that have been astonishingly effective. So I would just say that clinical trials, the story is just different when we're talking about a targeted therapy driver mutation population. Alice, I don't know, you've been that history, so I don't know if you have.
Yeah, it's very different. And certainly when we were probably all training in oncology, I think the expectation of phase one trials in the old days is that we probably wouldn't see much activity because we were mostly focused on the safety and how to dose the drug, but we weren't expecting to see necessarily much in the old days with old types of drugs. And these days, as many of you know, our phase one trials, we start those with a lot of preclinical data behind them, safety data behind them. I would say drugs like Alecensa and Zycadia, Alecensa, Alunbrig, many of those, we saw remarkable results in the phase one. And that really was a crucial point for many of my patients to getting access to those drugs and not waiting, for example, and potentially having worsening disease such that they couldn't access those drugs in the future. So I agree, Jack. The phase ones are very different these days, particularly for these molecularly targeted therapies.
Can I just have, we are joined by our patient leaders. If you can introduce yourself. Let me also say that one of the things that that the GRACE concept is centered around is that patients can be and often are experts. The whole idea is if patients are experts, if they are get access to great information, you can be amazingly sophisticated. Janet, are you you should be up here. I think. Why don't you come on up? Because I would invite everyone to. No, you can take mine. I'll stand. I can. It's the most exercise I'm going to get all day. Okay. Can I just have the patients introduce yourselves, because the faculty we've already covered. Let's start with Janet and just move down.
I'm Janet Freeman Daly. I'm a ROS1 cancer patient diagnosed in May of 2011. And if I make it to November, I will be 5 years no evidence of disease on crizotinib trial.
Congratulations.
Good morning. I'm Matt Hisney. I'm a 6-year survivor of ALK-positive non-small cell lung cancer.
I'm Sarah Whitlock, and I am a RET-positive 7-year survivor.
I'm John Kroll, diagnosed 2016 January, EGFR exon 19 deletion.
Excellent. And one of the requests I got, before I forget, for the entire panel, for the questions we cover, please speak up as best you can, okay? Because I'm the one with the mic and I don't need it as much. But
Jack, can I just say one other thing? It seems sometimes in lung cancer forums we talk a lot more about EGFR, ALK, ROS. I do want for patients or either here in live or online who may have lung cancer with other features, which is a lot more common, to speak up. We can sort of be very open to discussing those cancers as well. I don't want to give you the impression. I think when we are using the EGFR, ALK, ROS examples, it's more about illustrating how we are approaching these patients. But I don't want folks who may have other types of lung cancers or their relatives or other types of lung cancers not to speak up.
okay, so several questions, clinical trials. We'll get through as many as we can. A general one: what gets paid for and what doesn't in clinical trials?
So the clinical trials will, of course, cover, obviously, typically the experimental drug being provided is fully covered, and any, I would say, trial-specific expenses. So, for example, some of you who have been on trials know that some of the trials require a cardiac echo, an ultrasound of the heart to look at heart function. That's normally something we don't need to do for most of our patients, but trials may require that, and then that study would be covered. But what trials don't cover, and so I think it's a very good question, is trials don't cover all the normal sort of routine care that you would normally be provided by your oncologist. So, the normal lab work and getting scans to follow the cancer. That is typically covered by the insurance.
And I think, if I might run this, because you're on a clinical trial, does not mean that it might not be more expensive to you to participate, because you might normally be coming maybe once a month or once every 3 months. You might have to come every week for a clinical trial, and you may have to pay your copay to see the doctor every time you come. You may have to pay for parking every time you come. So there may be expenses that are not covered by the trial that you will incur to participate in the clinical trial.
There are advantages to traveling. I mean, I have to pay my travel. I fly from Seattle to Denver, and now I go every 8 weeks. Initially it was 2 weeks, and then it was 4. And I have to pay for the car, I have to pay for the airfare, I have to pay for the hotel, although I have people I can stay with in Denver now. And all of that, by the way, is tax deductible. But for me, it's worth the cost to talk to one of the few doctors that actually understands my mutation. I do see my doctors at home in Seattle, and if they have a question, they call my doctor in Denver, because they don't see that many ROS1 patients.
So, wanted to turn to a question of if a clinical trial is phase 1 in lung cancer but has done well in other cancer settings, does that give us more confidence about dose and efficacy, perhaps? Or just maybe as a general question, are we seeing more trials being done that are crossing tumor types and are being more directed toward ROS1 in many cancers, or particularly others, BRAF, V600E? I mean, how much can we extrapolate from one cancer type to another in clinical trials? Don't all rush in.
So I'm going to talk about BRAF later on, but I think BRAF is a good example where in melanoma we have a lot of information about BRAF, and BRAF has been described in lung cancer, and they basically went pretty much to phase 2 trial with both the single agent and the combination therapy, and got the efficacy data because the toxicity is the same toxicity. I think there are some cases where toxicity may be a little bit different, especially like a disease like melanoma where patients don't generally get chemo, and then you transition to lung cancer where patients may be pre-treated with chemo. So there may be some differences if there are differences in prior treatments and the types of other comorbidities people have, but in general the side effects are the same across, and it does help us move the drugs forward.
Yeah, there are some trials that are basket trials, so that anybody who has that mutation, regardless of cancer type, if it's a solid tumor, they can join. And 2 of our ROS1 trials were like that. But the problem we run into is that because it's not standard of care to test people for mutations in a lot of other cancers, these people aren't getting identified.
What about, we talked about liquid biopsies. For those of us who are writing, I don't actually write that many of these trials, and others of us, especially Alice maybe, are. Is there a growing trend toward allowing liquid biopsies to detect a mutation rather than requiring tissue? And you can perhaps speak also to resistance and serial biopsies. Is this something that, are liquid biopsies being adopted as an acceptable alternative, or are we still focusing on tissue as the gold standard?
I mean, for T790M, as an example, I mean, certainly have been trials that have allowed liquid biopsy results showing T790M positivity. Those patients, without having the tissue confirmation, have been allowed to enroll. And I think it kind of just depends on the actual mutation or target that's being studied and how well validated it has been in liquid biopsies. But Jack is correct. I mean, all of our trials these days all have incorporated liquid biopsies, both at the time of enrollment as well as usually a couple times along the way, and then at the time of progression. And some of that data has been slowly filtering back, I would say, especially in the EGFR T790M setting, but also in the ALK and ROS1 space as well, where we're actively trying to identify resistance mutations and hoping to be able to use these liquid biopsies, especially in patients who cannot undergo tissue biopsies. But I would say at least for the resistance mutations in ALK and ROS1, we still have a fair amount of work to do to really study the concordance and establish the concordance between liquid and tumor biopsies.
I think it's more common for the initial than for resistance under the T790M. And I would say that, and again, in our session, we're doing MET and RET and BRAF. And I know because MET and RET are so rare, there are many drugs that are being developed in these areas. Many of the trials have expanded to allow for diagnosis by liquid biopsy. And I know MET is a unique alteration where many of the patients are very elderly, and doing another biopsy doesn't make a lot of sense. And a lot of the trials are responding to that and allowing entry based on liquid biopsies.
A question comes up about biopsies and the highest sensitivity, what's got the biggest yield. Let me just offer some thoughts and others could comment. In general, we want to have it be the safest and most accessible tumor tissue, but what tends to work best, especially when we're interested in testing for several different things, is to get more tissue. So a core biopsy, or if there's a lymph node that's palpable, it might take out the whole thing. The more tissue, the better. But not necessarily you don't want to put people at risk. And so if there's just a small, difficult lesion to access in the lung, and we know there's a potential anytime you stick a needle in the lung that could lead to a collapse, it's not risk-free, and so if we can get an answer from blood, we'd use that, but the highest yield tends to be the most cell-rich, and that's often going right to the source if it's safe. So oftentimes when we're talking about the liquid biopsy, and Karen made this point earlier, it's just a first shot on goal. If it's negative, it doesn't mean you've stopped and it's truly negative. It just means that test didn't give an answer and you need to go to something potentially more challenging. Let me ask also, there was a separate question about brain. If you progress in the brain, does anyone have any enthusiasm for doing a biopsy in that case, or in that setting, does the risk generally exceed the benefit? For those of us, I know, Shirish, you've done a lot in brain progression. Alice as well. Maybe you can both comment on whether or how often you would consider a biopsy to get a better understanding of the biology versus that not being worth the risk.
In general, I don't think I've done a biopsy to define the resistance mechanism, but because most of the instances where patients have developed brain progression in the brain, usually they have been on a drug that does not penetrate or reach the brain in sufficient amount, and then we move them on to a drug where it does. I don't know if this is directly related to what you are saying, though. I will tell you, my sense is, and I would love to know what Alex thinks or any of the other panel members think, I have sensed that I've seen more patients develop something called as radiation necrosis after they've been on drugs that appear to penetrate the brain very well. So what I mean by this is, we do have patients who have had gamma knife or whole brain radiation first. Despite that, they have developed brain progression after being on a frontline drug, and then you move them on to the next drug, which does reach the brain very well. It seems to control the brain extremely well. Everything looks good, and then there's one area that keeps growing and growing to the point that it's a concern. And I can tell you of at least 2 patients in whom they underwent surgery, and what was removed showed nothing but dead tissue. And what this is known as radiation necrosis, and it tends to occur more after gamma knife, but can occur after whole brain radiation also to the brain. And my sense is we are noticing it a little more after using these drugs that reach the brain. And so what I would say is, I don't know if I've done a biopsy for resistance mechanism, but I will say that if you're seeing progression, especially on a drug that does reach the brain and it is not in multiple areas, that there could be a consideration of doing surgery to absolutely be certain that it is not radiation necrosis rather than progression. I don't know what.
Yeah, and medically that may be needed as well, because you can actually have quite a lot of swelling and symptoms from radiation necrosis, and so that's how we often end up going to surgery, because medically we need to do that to control the swelling. But I would agree with Dr. Gadgeel. I think in the phase 2 study of Alecensa, initially that was requiring that patients have treated brain metastases before they went on to Alecensa. And also we didn't really fully appreciate either how active it was. And so many patients who first went on to Alecensa had received stereotactic radiosurgery or gamma knife to their brain lesions. And in that setting, when they went on to Alecensa, we did have a number of cases where patients looked like they may have progression in one lesion in the brain, and they were even symptomatic, and it looked very worrisome for recurrence. Medically, we had to treat that, so they went to surgery. And I think in almost every case we did, it actually was confirmed as radiation necrosis, not progression of disease. So I would agree that that's an important point, that prior radiation can put patients at higher risk for having this issue once they go on to these very brain penetrable drugs. But like Dr. Gadgeel, I also do not routinely biopsy brains. I think that it's a possible procedure to do. We haven't routinely been doing that, but if someone has a lesion that's causing symptoms in the brain, and again, we don't always know we can't tell usually if it's radiation necrosis or true progression, those lesions we will resect with the help of neurosurgery, and then we do perform our typical molecular studies on those resected lesions. I would also note that we try to do liquid biopsies in patients when they have progression in the brain. And I would say if it's confined to the brain, in my experience, we very rarely ever will detect anything in the blood. I think it's just, again, probably an issue of sensitivity of the liquid biopsies
And these cancers have to shed the DNA into the bloodstream, and I think it's when it's confined to the central nervous system, the brain, we often just don't have enough in the bloodstream for us to detect.
A question that came in fact, a couple kind of similar ones about, again, is it significantly worse to have progression in one place over another, brain or bone? Brain used to be considered a particularly challenging and worse prognosis one, but as I think I implied with our concerns about being as minimalist as possible in treating the brain, that's because we have people, as a rule, living so much longer. Does anyone perceive that there's that much of a difference or a clearly worse result with brain disease? Because my sense is with so many of these now CNS, central nervous system, brain active medications, we are seeing many of these patients, living years and years and years with that. I don't think it's as much of an issue.
I think one challenge with the brain when it becomes harder to control is that it may not be life-threatening, but it can be very debilitating. And then often when the brain is uncontrolled and patients have had lung cancer for many years, leptomeningeal disease becomes a problem. And though the systemic disease may be controlled, our patients are generally younger and healthy, and the debilitating factor becomes a serious issue.
I think for newly diagnosed patients, there is and maybe you guys can comment on this, I feel like there's a psychological burden that's different with a brain metastasis than something else, because, that's sort of your brain with the body around it. And I've had, just this past week, I had a patient who was very gung-ho, very optimistic about treatment, but then after the MRI had brain metastases, and suddenly it was just completely different. It was very depressing and very unhappy. And these days, because we have more effective treatments, I think in someone without symptoms, it doesn't actually impact all that much how long people live anymore, because we have better treatments to address these. But it feels different.
I think I would have to, from the patient perspective, agree. I think when I got diagnosed and knew everything, it was when I got the MRI back and there was 5 meds in my brain. That's when I broke down. And I've had gamma knife twice, and everything's been great up there, but that was the moment. It was my brain. Everything else could have been on fire, but my brain was affected.
Well, because I think that I've also had a brain mets, and I think it is just that. That's you. That's who I identified. Like, my brain is me. And to think that the cancer was going to take me away from my children, from everything that I knew, that was really scary.
I'd like to turn to a couple of general questions that have come in online or here. One is about the risk of familial risk, and are my kids at risk? Is my family? There has been a general historical view that lung cancer is not one that is typically associated with family history or a syndrome. There's a little higher risk in never smokers who develop lung cancer. But there has also been what's called a germline mutation. So there's differences between the mutations we're talking about are generally what we call somatic mutations. They are not in all of your cells, but a random development that occur over time since birth, compared to germline mutations, which are the ones that you inherit and you're born with. And there has been a described germline that is familial T790M mutation in the EGFR gene. It's not common. Someone also asked, what is T790M? It's an EGFR mutation that is not typically something that you have at the time of diagnosis. It most commonly develops, if ever, over the course of treatment with one of the first-line agents. And then it's a mechanism that the cancer develops to evade an previously effective therapy. So it's seen in about 50 or 60% of the patients who develop progression on one of these previously effective drugs. So I'm interested in what the docs do. What do you tell a patient? How often do you recommend genetic counseling, if ever, in this situation? So the answer could be no.
We have a trial right now where we're looking at germline mutations in patients, mostly non-smokers or patients with genetic alterations. So we're doing it more than we used to, but it's mostly related to this trial. I think outside of a trial, the problem is if you're found to have something that's considered to be a germline mutation, we don't have recommendations about what to do with it. And that's one of the biggest problems, with BRCA, with breast cancer. We can make recommendations about getting mastectomies, getting screening, and things like that. With lung cancer, there aren't those recommendations, so then what do you do with that answer? So I think good genetic counseling has to go with testing, and that's really important.
But none of you is recommending genetic counseling for patients with this. Okay. What about thoughts on diet? A question came in. A patient is interested. This is obviously a situation where we all want control in a relatively uncontrollable or less controllable situation than we'd like. And we can give our medications, but in terms of lifestyle direction and control that you can exert, any recommendations about vegetarian or vegan diet or avoiding refined sugars? What do you say when your patients ask you?
I would love to know what the patients.
Yeah, so we were talking about that a little earlier. I said right after I was diagnosed, I didn't eat a cookie for a year, right? Because sugar, beating the cancer. But then I realized, well, I like cookies. Occasionally, it's probably okay for me to have a cookie. I have some kidney function that has decreased because of my treatment. I chose to go vegetarian because I could do that. I can control that. There's so much of this I can't control, but I can help myself by doing that. But I also think it's very easy to get in this space where you feel like if I'm not doing everything, then I'm blaming myself, right? It's my fault that I'm progressing. It's my fault that I have this, and that doesn't do anybody any good. So for me, it's all about moderation.
Yeah, initially I was, obviously, if you look at me, you know that I have no problem with eating, but initially I tried to be healthier, and I remember my big thing was, I was 24 when I got sick, so it was alcohol, and so I kind of abstained from alcohol, and I was going to try to be healthy, and finally at Christmas time and seeing family and friends rolled around, and I realized that kind of the switch went from this disease was going to control me, and I kind of shifted back into I'm going to be living with this disease. And so I remember calling up to Nate's office. Nate Pennell was my, doctor, and asking one, am I allowed to have a beer? And they're like, yeah, that's okay. And that's when I kind of knew that.
Did Nate say send me one?
And that's when I kind of shifted back into, all right, I'm going to be Matt. I'm going to live with this disease, and I'm not going to really let it control everything, though. Probably could have let it control me a little bit more in terms of I ate too much. But, I want to live with it. I didn't want to change too much, and I wasn't going to not enjoy life and everything that comes with it, diet and doing things and having a social life. At 24, I wasn't, going to give all that up. That was my take.
I changed my diet somewhat because of the side effects of my medication. Crizotinib is hard on the gut, so I've tried to have more bulk to make my gut happier, and I cut back on the sugar because I feel better when I do that. And my biggest thing is just making sure that I try and follow healthy. I get enough protein because my protein tends to be low, and drinking water. It's hard to drink enough water all the time. But I don't take supplements unless I need them for my overall health, because at some point I don't want to feel like my life is being controlled by the disease.
Any docs want to comment on how you respond about dietary recommendations? Or do you feel strongly?
They look at an Indian doctor and feel that I'm going to make some recipes or something like that. I have absolutely no clue about any of the Indian sort of spices or anything and their health benefits. This comes up a lot, and sometimes I can think of that it's very disappointing for the patient that I'm not making recommendations regarding the diet they should eat or foods they should avoid. And I think you mentioned it the best, moderation. I mean, I really don't think there's anything that you can't eat and you can't sort of drink. I think everything needs to be in moderation. And that is primarily because we have no data that a certain diet helps us control the cancer better. There is data to show that if you eat a certain diet over your lifetime, that it may or may not increase the risk of certain cancers, and the data is much stronger with breast and colon cancer. But as best as I know, there is no data that once a patient has developed cancer, whatever stage, particularly advanced stage lung cancer, that if you ate a certain diet or ate a certain, liquid diet or whatever, that we are going to be able to control the cancer any better than if you ate a normal diet. I think that that's the most important thing to recognize. I also will say that not every supplement that you get from a health food store is benign, and especially when you are taking it with your older drugs, there can be interactions. And so I really, really urge my patients that if they're going on a new drug, particularly on a clinical trial, to avoid things that they absolutely don't need, because you don't want to land up with a side effect and then you're not sure whether it's coming from the drug or it's coming from the interaction or coming from the supplement. So my advice really when it comes to diet is be as active as possible and eat anything and everything you want as long as you're doing it in moderation. I could never advise anybody not to eat cookie or cake and then go back to my office and eat one. So,
yes, I think Americans in general, we are kind of keyed up to think that our health depends almost entirely on our behaviors. You're bombarded with news reports, the coffee you drink, the green tea that you may or may not like because it's gross, or whether you're eating too much fat in your diet, then you're eating too much carbs in your diet. All of these things lead to whether or not you're going to get cancer or not, and it's very confusing. And so when you come in and we say, well, it doesn't really matter, it's upsetting because you've been keyed up to think that this is such an important thing. And so when we say, look, I don't really know what the right thing to do is, the truth is no one has ever shown any good evidence that any particular diet is better or worse when it comes to whether your cancer is going to get better or worse. Okay, that's basically what we mean. It's not that we don't care. It's that we don't really have anything to offer, and we're used to trying to offer things that have evidence behind them. I think it is a good idea to eat a healthy diet. If you want to cut sugar out of your diet because it's healthier to have fewer refined sugars, that's fine. Whatever works for you works. But, you do have to appreciate the quality of your life. This is your life now. You're living with cancer, and the rest of your life, you have to be happy with that. And so you should do the things that are enjoyable for you.
It's more fair assessment to say that it's not related to the cancer growth or that, but it's more related to the side effects, as Janet said, that those particular things could more address helping the side effects than the progression or whatever.
There's certainly plenty of patients who find that certain dietary things cause more diarrhea with EGFR inhibitors, for instance, but I would say, it's all empiric. That is, how is it for you? My view is largely the same as Nate's, that it's probably healthier to eat less meat. We, as a society, eat a lot of fatty meat-based meals, and it's fine if people want to, and it's not too strenuous to be more plant-based, but I wouldn't want to put too fine a point on it. I think that I see things the exact same way as Nate, that there's really no evidence that changes outcomes in a meaningful way. It's just not unhealthy. It's great. Avoid refined sugars and eat a balanced diet in moderation. And I think the flip side could be putting too much pressure on yourself, that it's just, everything that happens comes down to some failure on your part or something that you ate that you shouldn't have. And that I think it's a big mistake to fall prey to this idea that there are miraculous diets out there that fight cancer effectively. They just have no evidence to support them. And things like alkalinization or the Budwig diet are just hooey at best and detrimental at worst. And
Why do you think it hasn't been studied?
No.
It's such an obvious thing.
Yes, they haven't been systematically studied, but there have been lots and lots and lots and lots of people who have been zealous advocates of this. If it was anything close to what is promised, we would know that. I think that it has been pursued, many of these have been pursued for decades, and if they were anything close to what they promised, we wouldn't be able to say there's no evidence for it. They would be wildly obvious that they were effective, because too often, and I'm going to talk about this in the afternoon, relying on anecdotal cases of my sister's friend's cousin tried this and did well, is that a broken clock is right twice a day. And that, you don't have the denominator. You're not seeing the testimonial of the other 100,000 people who did this and bought the product or did this diet and did not do better than they were supposed to do. So, and sometimes things that are miraculous improvements of cancer, maybe it is that, maybe it's a pneumonia that was misinterpreted as cancer that got better. Now, Shirish, you brought up supplements. It's a question that came up in several of the questions. And so, what are people's perspectives on supplements? You've already commented. My view is that a multivitamin is perfectly fine, but I'm hesitant about more variables, and I would caution that anything that can have supposed anti-cancer effects and is biologically active can also be detrimental. I mentioned that in our cancer research clinical trials, we have a precedent for some of the treatments we thought would be great actually not even being just ineffective, but harmful compared to a placebo. And I'm at least as cautious about things that you can buy at super supplements as I am from something that comes from a lab at AstraZeneca. That it should be just as rigorous. We should not give a free pass and presume that just because in a lab something worked or someone's selling it and says it's immune boosting, that it's effective. And so I'm particularly cautious about megavitamins and other supplements that at best have no evidence and at worst could counteract or intervene with the things we're doing. Nate, maybe you can give a thought?
Yeah, I think you're absolutely right. I mean, just because something is good for you in general doesn't necessarily mean that it's going to be helpful for the cancer. And when it comes to vitamins, biology is pretty clear. You need enough vitamin in order to do the purpose of the vitamin, but then beyond that, at best, it does nothing. And you usually just kind of pee out the rest. But there actually are very specific instances where we've done trials when we've had large trials to either prevent cancer or treat cancer, and some in specifically lung cancer, with high doses of things like vitamin A or vitamin C or vitamin E, these antioxidants. And it turns out they're actually protecting the cancer rather than helping you, because your cancer has focused all of its systems on surviving and making more copies of itself. It may be better at using these things to survive than you are.
What about vitamin D? Because some of us are
right.
higher doses because we're insufficient.
Yeah, so I won't pretend to be an expert in vitamins. I do think that vitamin D deficiency seems to be quite common, and there are good reasons for it. But from a cancer perspective, I'm not aware of any evidence that is better to take high doses when you already have cancer. But I'm not aware that there's evidence.
No, I wouldn't overstate things either to say that that we have demonstrated a harmful effect of X, Y, or Z with all of these. It's just they're unknowns. Now, vitamin D is interesting because there's an epidemic of, you won't find a fever if you don't take a temperature, and there's rampant vitamin D deficiency relative to the somewhat arbitrary numbers that are used. And I was on vitamin D for several years because I'm from Seattle, and everyone in Seattle is vitamin D deficient, at least for about 6-7 months of the year. But talking about it further with my physician after years, the data have not been that clear that it improves anything. That's not to say it's harmful, and I think that correcting a deficiency is different from taking mega doses of something.
Yeah, also vitamin D we do prescribe when they have bone mets, and they are being given these bone modifying agents like bisphosphonates and fever. You do want to supplement with calcium and vitamin D. There have been lab-based studies to look at vitamin D. Maybe it is protective. Enhances even effects of chemotherapy. But up till now, the data in lung cancer has been disappointing. Whatever limited data that I'm aware of. In that, I don't know of any harm, but how effective it was in controlling the lung cancer. But yes, vitamin D is recommended for, of course, if there's deficiency, but also many times with these bone modifying agents in patients with bone metastasis.
I wanted to cover a couple of other questions. One is, if you have a target that there isn't an effective therapy for, say KRAS, how can you ensure that you're being kept up to date on things? And my thought on this is that if you don't have an oncologist who eats, sleeps, lives, and breathes lung cancer, it can be helpful to see somebody who is a real thoracic oncology lung cancer specialist occasionally, every 6 or 12 months, just to make sure that, because I think it is not realistic or fair to expect that every oncologist in every community who treats 15 or 20 different cancers a day is going to know every development. That's just a different world. That was viable at a time when all of medicine could be encapsulated in a volume or two. But it's no longer that world, and it's not fair, it's not real. And I think you just need to either keep up online, which I think can help, or...
If only there were a website available.
Yes. Yes. Well, actually, I would say that is a fair point, that, you could also put up the bat signal at Grace and find out, Jim is one of our amazing monitors in the back, and he knows essentially everything. We would have, if it weren't illegal, we would have made him a physician already. But it would be a demotion from his lawyer status. But you could do that. But certainly, a lot of us see patients who we aren't always treating all the time, but are just part of a team to supplement the local care that people get. So that's my view on it. I don't know. Besides,
in this world now where we have genomics and what was one disease is many diseases, and I think this is most serious diseases that people get diagnosed with, getting an opinion and having some intermittent follow-up with a specialist in lung cancer at a comprehensive cancer center. I mean, there's really a relatively small number of us even around the world, and we get together a handful of times a year. And so if you're connected to one institution, we kind of know where other people have certain things, or can at least connect you with other certain things. It's kind of the ALK and ROS1 story is a good story for that. At the beginning, we couldn't even test for ROS1, so I would send my patients down to UC Irvine where they were testing for ROS1. And so as long as you're going to people who know, if you're in a community site, they're not always going to know, and really connecting or going on the Grace site and getting more information. But this is a different world, and when you're diagnosed with something serious, you should be informed and try and get all the options that are possible.
A question about, we have patients who we routinely now can say, come back in 2-3 months, and we might go 4 or 6 months between scans. What do you tell patients to be on the lookout for in terms of signs, symptoms, et cetera, that might lead them to want to contact you before then?
I mean, I would say any new symptoms could be a concern. Obviously, if it's a sprained your ankle, I mean, that's not as worrisome. You have a clear reason for that. But I think anything new and unexplained, and that's not clearly getting better over time, is something we want to know about. So, for example, I often tell my patients a new pain in the bone, a headache, a cough that's not a simple cold that you've had. Really, any new symptom, worsening fatigue when you haven't normally you've been working fine and doing everything normally, and now you're really wiped out. So usually it's just any change in how you're feeling that is not easily explained by something else.
We always have to challenge as patients now that we have cancer. Is like, is this a headache? Or is it a brain met?
Yeah, and that is true. And what I tell my patients is, let me figure it out. So, if there's a symptom, don't feel. Yeah, I will admit to you that there are times when I get called and I will. Hopefully, I've never told that to a patient or communicated that to a patient. But yeah, I might get a little irritated just because I'm a little busy. But I just tell my patients, don't try and figure it out. I'd rather you call me and be sure that we have all my nurse over here and we sort of address it than you trying to figure out, is this related to a cancer?
Sometimes the anxiety can build up so much that then the symptoms become worse. And we've all had patients who have symptoms because of anxiety as you're getting a scan. Sometimes that's okay, but you should let your team know, because we can help understand whether it's serious or not serious. So if it's causing you discomfort or anxiety, you should at least bring it up to the team.
Good specific question. We talked about local therapies, oligoprogression. What do you tell patients about continuing versus stopping their systemic therapy if they're getting 4 fractions of stereotactic or SABR? That's typically a handful of treatments over a week or two. Do you tell patients to continue on their oral therapies, or do you tell them to stop and resume it?
Yeah. I mean, patients on cytotoxic chemotherapy, we try not to maybe overlap exactly on the day of treatment and stereotactic. By and large, for these for short courses of radiation, they're very safe. And it might be a little different if you were giving very high doses of radiation over a long period of time. But generally, we don't stop.
Yeah, it's really so focal. In fact, I've heard some people say, someone was joking that the radiation doctor say, your regular doctor told you to stop, don't, just keep going, or vice versa. But it's not been studied that carefully, but I think it's probably a very reasonable, safe thing to do, because you're talking about extremely focal radiation. It would be different if it was a broader area being treated.
And there are reasons to believe that sometimes stopping these targeted drugs can be bad, and the cancer can get worse pretty rapidly.
Well, yeah, it depends also if you're talking, the shorter the interval, the less of a concern. Right. But we have seen so-called flare reactions sometimes within a couple of weeks. So it's something to be cautious about.
The other issue of progression, it's not all or nothing. And so when you're on, especially for targeted therapies, I've had people come as a second opinion and they've been told, your tumor's growing. Give it EGFR as an example. There's no T790M. We're going to stop. We're going to give you something else. We're going to look for trial. But they stop the drug, and then within a few weeks they feel worse because some of that tumor was being controlled. And so absolutely you don't stop the drug until, if you're going on a trial, you're hitting that window where you have to come off the drug, or until you're starting your next therapy. And that's really important with these targeted agents.
Another side on that is that now that a lot of us are being around longer, we might consider a surgery or something for, like I had a surgery on my foot that I hadn't worried about. And the Pfizer trial actually asked me to stop crizotinib for 2 days before the surgery and 2 days after, which surprised me.
Question came in online about local radiation or some kind of local therapy for patients with a pleural effusion. And I think we should comment just for a second to say that the trial that Dr. Gadgeel highlighted about consolidation or local therapy in patients responding actually excluded patients with pleural effusions. So if that is the site, that is really not amenable to a local treatment. There have been Japanese studies in particular that have done extremely aggressive surgeries or other interventions. They just don't work. So in that trial, the patients with cancer with a malignant pleural effusion, it's called, were not included in that. So that is really one that is singled out as not amenable, unless other people have comments. I think that's what I'd say about that. What about clinical trials and eligibility? Are you seeing over time a liberalization of eligibility, particularly about comorbidities and anticoagulation? Many of you may be on blood thinners. That and brain metastases are areas that really can be sticking points for some patients who are suddenly not eligible for a clinical trial. You know, the 3% I think is a dismaying thing, but I think it's a product of many patients themselves being concerned and resistant because of perceptions, misperceptions. Sometimes the docs not having access or interest in sending patients, but also many patients having issues that keep them from being able to get on trials. So I'll ask Alice directly. I mean, what's your sense of eligibility for trials, and is there, over the time that you've been doing this and writing trials, a conscious effort to liberalize eligibility?
Yes, it's a really important question because eligibility is often an issue, and fortunately we have seen more of a liberalization over, I would say, the last decade, especially with the targeted therapies. As an example, Jack was mentioning comorbidities. It was very, very common for many trials to exclude you if you had a prior history of basically any cancer in the last 3 years, even if it had been curatively treated. And fortunately, many trials I'm seeing now have sort of many exceptions for that. You know, if it's an early stage cervical cancer, early stage breast cancer, as long as it's been treated with curative intent, I definitely see that the eligibility has been loosening on that, which is helpful for many of our patients. The other thing that Jack mentioned, which is important, is the brain metastases eligibility. And it's hard to believe, but with the trials of Alecensa and Alembreg, when they were in phase 1-2 testing, they actually both required treatment of brain metastases. So if you had like a tiny 2 millimeter speck in the brain that obviously was not causing you any problems, you actually were not eligible unless you had that little speck treated. So there had been a lot of concern because back then we didn't know as well how brain penetrable these drugs were, and we were also worried, I guess they were worried at the time, that if you had any sign of brain metastases, that was a sign of worse prognosis. So fortunately, that has really, I think that has changed pretty dramatically. Many, as you guys know, many of the targeted therapies do allow patients to enroll as long as the untreated brain metastases are asymptomatic. And that's even in phase 1 trials where we may not even yet know how brain penetrable they are, but we all recognize that we're going to be following the brain closely. And there can be very clinically insignificant tiny brain metastases, you know, these 1 or 2 millimeter specks that really are not going to necessarily cause any problems for a patient enrolling on a trial.
Great.
How about with ground-glass opacities?
Measurable disease?
Yes.
Yeah.
That, I think, remains an issue because as we were talking about in many trials, efficacy is an important endpoint, especially obviously phase 2, phase 3, but even the phase 1 trials where we're looking primarily at safety and dosing, there is still the hope we will gather information on efficacy. And if someone comes on a study without what we call measurable disease, meaning the radiologists do not believe that they can actually there's strict criteria for this, but basically if they don't believe there's something they can define as measurable, for example, it has to be, if it's in the lung as a spot in the lung, it has to be measuring a centimeter or above, just as an example. Or if it's a lymph node in the chest, the shortest axis has to be measuring 1.5 centimeters. There are all these really strict rules about it. Then even though we know a patient may have active cancer, they don't have this measurable disease to make them eligible for the trial. So it is a potentially big issue. And Janet's referring to another sort of sort of offshoot of this, which is that certain lesions, although it may measure 1 centimeter or even larger, but it's kind of hazy in the lung, such that the radiologists don't believe they can accurately measure it from scan to scan. They will end up calling that non-measurable, and again, a patient will not be able then to enroll on a trial. So that is a big issue. It's a hard one to get past, though, given that the requirements typically as eligibility are to have at least 1 measurable lesion.
Thank you. So thanks to our panel so much. That was a great session. We are going to go down to the first floor for lunch where the faculty will be at tables. I also want to announce for those online who are following, want to follow EGFR or the MET-RET, what is it, the BRAF session, those are not going to be viewable on an Apple device unless you're watching something with flash capacity. So hopefully we can make those available to people in other ways. Yes, it's sponsored by Microsoft. So thanks. And we reconvene up here at 1 o'clock, I believe, for the sessions.